Good afternoon. It's now 1:30 and I am pleased to open the third of our virtual meeting series of the National Research Summit on Care, Services, and Supports for Persons with Dementia and Their Caregivers. Next slide. Next slide. My name is Jennifer. Oh, go back. My name is Jennifer Wolf, and I've been honored to co-chair the 2020 Summit with Dr. David Rubin, who you will hear from shortly. Next slide. This event has been made possible by the National Institute on Aging in collaboration with the Foundation for the NIH. The organizations listed here made generous contributions to this event through the FNIH, including the Alzheimer's Association, who is a lead sponsor. Next slide. The primary outcome of the 2020 Summit is the identification of gaps and opportunities for research priorities to inform federal agencies, foundations, and private sector organizations. To set the stage for these gaps and opportunities, the summit will also summarize the state of the science and highlight progress that has been made since and as a result of the 2017 summit. Next slide. The bulk of the 3 virtual meetings have been structured around 6 themes, which are listed on this slide. The first 3 themes focus on persons with dementia and their caregivers and understanding impacts of the disease and their experiences. Themes 4 through 6 are directed at the way we do research. Today, we focus on session 5, intervention research, dissemination and implementation. Session 6, research resources, methods, and data infrastructure, as well as a panel on emerging topics. I'd like to note that the description of each theme and related gaps and opportunities are provided in the online program book and website. Next slide. In addition to the themes, a number of cross-cutting issues were identified. These cross-cutting themes include the importance of understanding and incorporating the perspectives of persons with dementia and their caregivers, disparities, ethics, technology, and etiologies. Presenters have been encouraged to address each of these themes in their presentations, which are a prominent feature of today's emerging topics theme. Next slide. A critical element of summit planning has been ensuring that we are listening and incorporating the perspectives of people living with dementia and their family members and other care partners at each step in the process, including issuing a request for information more than a year ago at the outset of the process, assembling a steering committee with diverse expertise, eliciting and coordinating critical input from 5 stakeholder groups coordinated and convened by the Department of Health and Human Services Office of the Assistant Secretary of Planning and Evaluation, led by this work importantly led by Katie Maslow, engaging federal partners in the National Alzheimer's Project Act Advisory Council, and engaging audience participation before, during, and after each of the summit meetings. During the first 2 summit meetings, we heard from Lonnie Schicker, Katie Brandt, Cynthia Huling-Hummel, and Lori Scherer, who we thank for their important insight. And today we'll be hearing as well from individuals who are living with dementia. I'd like to now invite my co-chair, Dr. David Rubin, to discuss process and logistics with respect to summit activities, as well as today's meeting. Next slide.
Thank you. I'd like to also offer my welcome to everyone. I'm going to recap the bidding a little bit. On July 10th, we had our first virtual meeting, which focused on theme 1, the impact, and theme 4, the participation of persons with dementia and their caregivers in research. On July 21st, we focused on long-term care services in various settings and medical care settings, as well as a unique integration of the themes 2 and 3. The recordings and slides of these are available at the Summit website, and I encourage people to look at it. On last Friday, August 7th, we had a very novel virtual Twitter poster session that was great, and it's also available for people to view. Next slide, please. There we go. And this is an example of 3 of these. And the way this works is you look at one, and again, every few seconds it advances, and you can view it as many times as you want. These were quite good, and there was a lot of audience participation. Next slide, please. So we are inviting people to participate, submitting questions and answers for today's session. We won't be able to get to all of them, but we will do as many as we can. We also encourage you to respond to the RFI to indicate suggestions for modifications of drafts, gaps and opportunities, or suggest new ones. And then after the summit's final gaps and opportunities are completed, which will be around the beginning of the year, we encourage you to stay engaged and work towards implementing this research. Next slide, please. So today, we are going to have talk about emerging topics, interventional research dissemination and implementation, and research resources, methods, and data infrastructure. Each of these sessions will include short research presentations, introduction of draft research gaps and opportunities, and panelist perspectives, and then a moderated question and answer session. And here we invite people to submit questions so we can present them to the panelists and speakers. We are going to keep the introductions very brief. I would encourage people to look at the agenda where people's full biographies are listed. These are interesting people, read about them. So we're going to begin with the emerging topic section. There will be 3 research presentations. The first will be by Joan Moynin, who is Associate Professor at the Yale School of Public Health and has been devoting her research career to understanding and improving the emotional lives of caregivers. This will be followed by Jared Beng, who is a clinical neuropsychology at Baylor Scott & White, who has been interested in assessment and patient-centered outcomes. And finally, we'll hear from Christine Castle, who is a senior advisor for strategy and policy at UCSF and is a national leader in geriatrics, bioethics, and quality of care. So, Joan?
Hi, thanks so much for having me. I'm going to be talking about emotional functioning in persons living with dementia and their care partners. Next slide, please. My disclosures are that I'm part of the design and statistics core of the NIA Impact Collaboratory, and I receive funding from the NIA. Next slide. So I'll be talking about emotional processes that affect the health of persons living with dementia and their care partners. I'll talk about individual differences that affect emotions in caregiving, and what this means for interventions and a few directions for the future. Next slide. So traditionally, caregiving stress has been studied through a caregiving stress health model, which really focuses on the disease-related stressors. So functional disability, cognitive impairment, disruptive behaviors that a person living with dementia might experience. And then this is thought to lead to caregiving stressors, such as the type and quantity of assistance provided. And this is mostly focused on as the actual practical helping behaviors or, actual types of assistance that they're giving. And then also vigilance demands, so making sure the person is safe. And this is often measured as time spent caregiving. And this is thought to lead to caregivers' psychological and physical health problems. Next slide. But what about the emotional processes here? So first of all, what are emotions? And actually, there's no scientific consensus on the definition of emotion. Really, emotion researchers haven't agreed on what emotions are. So this makes it a little bit tricky. But when I think about emotions, I think about thoughts, feelings, or behaviors, plus physiological arousal of some type. And we can also think of it as degrees of pleasure versus displeasure. In the caregiving literature, you don't really see many emotion measures used. Oftentimes it's depressive symptoms, caregiver burden, maybe some self-reported emotion adjectives, physiological indicators like blood pressure and heart rate. but you don't really see a lot of the emotion measures that emotion researchers would usually use. And I just recommend that there's a great Yale course by June Gruber called the Experts in Emotion series if you want to check out the research on emotion more broadly. Next slide. So the experience, expression, and perceptions of emotions in caregiving are important to consider. So you could measure the care recipient or the person living with dementia, their experience of emotions. You could ask them how they're feeling. You could look at their behaviors when they express the emotions, but you don't know whether the experience is always getting to the expression because there could be suffering in silence or inhibition of emotions or exaggeration. And then you have the caregiver's perceptions of emotions, and those could be just inferring what the care recipient is, thinking, or actually witnessing expression of emotions from that care recipient. And caregivers have individual differences that make them more likely to see those types of emotion expressions or infer those feelings about the person living with dementia's experience. So things like empathy and relationship closeness, intimacy, individual differences in how secure their relationship is with attachment. And then these perceptions of emotions are thought to lead to the caregiver's response. Next slide. Now, much of the research on dementia caregiving and emotions really focuses on negative emotions. So much of the work that Richard Schultz and I have done is really about perceiving that a person living with dementia is suffering and how that leads to poor psychological and physical health for family members, above and beyond the severity of the disease or the actual helping that they're giving or those behaviors. There's also a large literature on the experience of guilt in caregivers as a separate outcome from burden and depression. And then there's a growing literature showing how caregivers who are depressed actually, that's associated with persons living with dementia not as long. So when caregivers are really stressed out, that has important implications for the person living with dementia. Next slide. There's really been a shift recently to think more about positive emotions in health in dementia caregiving. And this is also a reflection of psychology, positive psychology, which took a while to happen as well. And we've known for a long time that positive and negative emotions have independent effects on caregivers' well-being. So caregivers aren't only feeling negative or positive, they're feeling both. But it just depends on kind of how much they're feeling each one for how it's affecting people's health. There's also been a movement to have more positive measures of caregiving. So positive aspects of caregiving is a common measure that really gets at meaning and purpose of life in caregiving and gratitude and things that come from caregiving beyond just the stressful aspects. And then positive emotion expression has been shown to be protective in both partners. So this is taking the view that we really want to be looking at more than the person living with dementia, but also their care partners and potentially other family members. So some of my work and others' work has really focused on love as an important factor in the quality of life of persons with dementia and care partners. We're also seeing some great observational coding work about how genuine smiles from persons with dementia are associated with caregivers' better mental health. Next slide. It's really important to consider individual differences when we're thinking about emotions in dementia caregiving. So we're finding that emotional experiences of persons with Alzheimer's disease are different from frontotemporal dementia. And so people with frontotemporal dementia tend to have different behaviors that may be more stressful for caregivers to witness. So we're finding that, especially for spouses of people with frontotemporal dementia, it can be more difficult to perceive those expressions. Can you go back one? Thanks. We also see that women tend to report more distress than men in caregivers across different contexts. And then there's mixed evidence on the cultural and ethnic differences in how caregivers respond to the demands of caregiving. So we see that there's greater familism in Latinos and greater filial obligation among Asians and more religious coping among African Americans. But it's unclear about whether these things are protective or not protective. So familism and filial obligation are really kind of the sense from the culture that it's a duty to be a caregiver. Really, if that's your parent or your loved one, there's really no option but to express your love and your devotion to that person. Next slide. So what this means for interventions, we need to focus on emotional experience and expression in caregiving, in addition to thinking about the practical kind of care tasks that caregivers have, or the functional ability or the cognitive decline. And we need to think about it in an interpersonal way, because emotions don't happen in a vacuum. We need to include both the person living with dementia and their primary care partner in interventions, and potentially other family members, because each person's emotion is going to affect the other. And we need to target and tailor to the needs of different groups and individuals. Next slide. So advance, yeah, thank you. So there's some existing ones that are out there that are pretty good. So mindfulness-based approaches, next. Physical activity, next. Cognitive behavioral therapy. And there's more evidence for caregivers' positive emotion effects than for care recipients. Next slide. There's also promising interventions like music and memory for persons living with dementia, and positive affect training for care partners, which positive affect training really combines like gratitude, sharing positive emotions, keeping track of positive events. Next slide. So what we really need to do is obtain better emotion measures for persons living with dementia. We need to address the emotional needs of persons living with dementia. We need to develop interventions that address close relationship processes. And then also, I would say we need to collect information in a more pragmatic way from the healthcare system, so that when we do these interventions, we have information for more than just the person with dementia.
Thank you so much, Dr. Manan. It's time to move on to the next topic. We appreciate all of your sharing. Thank you.
Hello. My name is Jared Benge, and I'm going to be presenting on a concept we call technological reserve in persons with dementia. Next slide, please. A few disclosures here. Our work is supported by the National Institutes of Aging. We received smartphones from Microsoft Corporation for a previous iteration of our work, and the ideas I'll talk today have been developed with my primary collaborator, Dr. Scullin at Baylor University. Next slide, please. The idea of technological reserve stems from kind of a holistic view of looking at the process of dementia. So in dementia, you have these microscopic changes in the brain that lead to changes in thinking skills. And those changes in thinking skills lead to changes in day-to-day functioning. So when you're thinking about intervening in dementia, of course, you want to focus on developing interventions to target the changes that are happening in the brain. You also want to target the actual changes in cognition. But an area that's received less support is things that we can do in the environment to help mitigate the impact of the disease on day-to-day processes. We believe that technology can serve as this very important form of reserve, where we build an environment where technology buffers the impact of cognitive changes on real-world functioning. Next slide, please. When you think about technological interventions for persons living with dementia, there's a number of different strategies or kind of groupings of technological interventions that may be helpful. The first, and one that our group focuses on, is the idea that technology can serve as a cognitive prosthetic. And so examples of these types of interventions would be things like teaching individuals to use a reminder app on a smartphone to help with prospective memory lapses, utilize GPS to get around navigational difficulties, or even in other forms of neurodegenerative processes like primary progressive aphasias, perhaps using technologies to serve as augmentative communication strategies. Next slide, please. There's also groups that are working to develop technology specifically geared at independence at home and in the community, as well as safety in those settings. Great examples of these are smart home systems. Smart home systems are kind of an amazing opportunity for these automated processes that help prompt to initiate particular behaviors day to day, monitor for errors, prompt for the next step, and provide feedback along the way to help support independence for activities like in the kitchen or for medication management. As the technologies advance, you can imagine that these sorts of applications will expand, though, where self-driving or assisted driving cars or ride-sharing apps may become something that can be useful to get around mobility limitations and neurodegenerative processes, tracking to help mitigate some of the devastating effects of wandering in some individuals. Next slide, please. Technology, as Dr. Monin just talked about, can also be served to help promote well-being, social connectedness. So for individuals living with dementia and their care partners, technology can help bring people together, as we're doing today and have over the course of the pandemic, using technology to bring groups together. Technology can also be used to help provide reminders for these daily habits that are very important, like exercise and mindfulness, which are known to help mitigate the impacts of dementia on day-to-day activities, but sometimes we might need prompts for that. Also, technology can help promote connectedness with treatment teams, particularly for specialized treatment teams that may be far away from where individuals are living. Next slide, please. Finally, for systems and communities, technology holds enormous potential for improving care for individuals living with dementia. So these may be things like using systems within electronic health records to detect medication errors or non-compliance, non-refills of treatments, helping to facilitate true communication across providers as well as family or other care partners, as well as the person living with dementia. And then systems that help support independence and safety in the broader community. Next slide, please. For all of the enormous promise of technology to help day-to-day activities in individuals with dementia, it's important to look at the evidence base here. And there are some amazing labs, there's some amazing papers. Every day, every month, new information comes out on this domain. And I highlight just a few of the exciting projects and exciting labs here. There's others in the references portion of my slide, and even more that I could put into a 10-minute presentation here. Next slide, please. Despite all of this work, though, it's important to note that high-quality randomized controlled trials are relatively lacking in this world. This really is kind of an emerging topic. And so you look at, for example, a Cochrane review in the area that I look at using assistive technology for memory support. And as recently as 2017, when the Cochrane review was conducted, there weren't any studies that met rigorous inclusion criteria for some of the most rigorous trials to promote this. So more work clearly needs to be done. Next slide, please. As we develop this field, as this field emerges, though, I think it's important to look at potential pitfalls or areas that could trip up the development of this literature. So the first is just overall access, particularly for aging populations that are at risk for developing these conditions. Do they have access to a tech-enabled environment, access to high-speed cellular service, Are they going to have that inevitable tech support, or how do we avoid making technology a burdensome impact on care partners who are doing other things to help day to day? And what is the impact of racial, ethnic, socioeconomic disparities on utilization of technologies? Next slide, please. Another pitfall here is, can we build stable and usable platforms? And if you think about the lifespan of technologies, there's an economic impact for technology companies to advance every year, constantly move forward. But if you think about individuals living with dementia, typically they rely more on procedural memory, overlearned memory systems, rather than episodic memory. And so learning new technologies can be an incredibly difficult experience whenever, say, elements of the applications change or home buttons go away. Okay. Finally, you think about the role of a clinical researcher. Oftentimes, it can take several rounds, a year or more to obtain funding, several years to complete a study, and then disseminate those results. And of course, the technologies that we're studying may have changed rapidly over that time period. Next slide, please. I'll also say a word about privacy risks. Technology produces big data and has amazing opportunities for generating real-time, in-the-world type data. But how do we de-identify those data sets? How do we explain data risks to individuals who might participate in our studies? How do we explain that to other stakeholders like IRBs? And how do we weigh the pros and cons of things like in-home video monitoring and other sorts of interventions that hold potential, but also come with privacy risks? Figuring out these questions will be critical as this field evolves and goes forward. Next slide, please. Finally, we'll say a word about technological literacy. I believe in the field of technology, we're going to see enormous cohort effects as individuals age and move into the zones where they're at risk for developing neurodegenerative changes. We need to understand how their previous experiences with technology might promote or interact with the neurodegenerative status to make some interventions more or less useful. We also need to see if this technological literacy is something that we can develop or promote, particularly as we move toward identifying these conditions early on. Can we use that time to build in the habits and the environments that can help mitigate the effects of technological, or help mitigate the impacts of dementia? Next slide, please. So the path forward for this field, we have to understand, promote, and improve the tech environment. We have to collaborate with persons living with dementia, care partners, and technology experts. We need to include approaches that help us develop secure and ethical ways of managing this data. And we need to understand the individual for the factors at the level of the individual to help pick the right tool for the job. Next slide, please. And so lots more references and reading. Thank you very much for your time.
Hello, my name is Christine Castle. Next slide, please. These are my disclosures, and I'd like to particularly focus on the last one. I'm a physician, geriatrician, spent my career working in the interface between geriatrics and bioethics, and now also am in the transition between pre-caregiver and caregiver. When David Rubin invited me to participate in this summit, he didn't know yet that my husband, Mike, had been diagnosed with early Alzheimer's disease. That happened through a study at UCSF that was in the very earliest stages of mild memory problems. And it was only through the information that we received in that now 3 years ago, and since then annual reassessments, that we've been able to have more understanding of the changes that have been occurring, and also more ability to think about it and plan for our future. So I come to you as both a professional in this field and also someone who is a caregiver and hopefully the subject of some of the important research that we're talking about here. Next slide. So we know now that early diagnosis is possible, and even what's called preclinical. I would challenge us that from my perspective, as a spouse of someone with this condition, even how defining preclinical, we tend to think of that as genetic diagnoses, and indeed more and more people are now seeking and getting this information, and we need a huge amount more knowledge about how people deal with probabilistic data and how to understand both the communication about it and also how people understand it or may misunderstand it, and also from whose perspective is it really valuable. Now, it also sets us up for being able to do an early intervention research, and so we want to make sure to understand how people understand participation in research, but also at what cost are these diagnostic techniques. Participating in a research study funded by NIA is a great gift, or at least it was to us. But if people start really wanting this information because it helps improve their lives, then how are we going to make it more affordable? What are the therapeutic implications? And most importantly, what is the impact on our lives of information, pure and simple information? Because much as you know, much of this early diagnosis doesn't really offer a therapeutic option. Next slide. So as we talk about the effects of information, a lot of the research that's been presented here and that is in the literature is on patients and on caregivers, and that's really important. I would urge us to also think about more research is needed about the effect of this information on clinicians. Clinicians are not immune from the attitudes and biases, sometimes implicit, that have to do with people with cognitive impairment. But also there's been more and more attention to burnout and moral distress as stressors on clinicians. And some of that comes from clinicians like primary care providers, for example, being faced with situations where they really don't have a toolbox and they really have inadequate skills to deal with an information. So they might not actually seek to evaluate cognitive function or to be able to respond to it very carefully. And then communities. I think here's where we really have to recognize that we are just at the beginning of the aging baby boomers, and stigma still is with us. Next slide, please. What do we know about stigma? Not enough, I would argue, that this is still a huge barrier to seeking diagnosis and to living as in the best ways we can, to quality of life for people in particularly their early stages or even preclinical stages. What is the role for activism or education? What works in addressing stigma, and how can research help us? I would just remind us that it's been 40 years since Rob Butler wrote Why Survive, that led to the founding of NIA, and he talked about the stigma of ageism as well as of cognitive decline, to Arthur Kleinman's The Soul of Care, where he describes facing exactly the same challenges with the diagnosis of his wife. Next slide, please. So for all of this, ethics helps. And I put ethics in quotes here because not everyone understands the extensive possibilities for research in bioethics, and particularly that this condition presents us with. We tend to think of ethics as procedures, rules, and regulations. We have rules for advanced care planning, living wills. We have rules for clinical decision-making, informed consent. We have rules for participation in research, IRBs, and we have rules for disclosure. We tell about conflicts of interest at the beginning of a presentation. We even have some beginning emerging research about disclosure of errors in medicine and diagnosis or in treatment. But all of these areas actually have more unanswered questions than they have answered and settled rules about how we deal with it. So just to take clinical decision-making, for example, the use of digital information and artificial intelligence and machine learning is more and more widespread. And how does that affect shared, what we think of as shared decision-making? Participation in research, we're going to hear later about embedded research, other kinds of big data and participatory research that doesn't allow for the traditional ways in which we think about individual decision-making. So let me just, in conclusion, talk a little bit about some areas, such as Jared just mentioned, all of the incredibly promising work that digital monitoring and robots and other kinds of new technologies bring with them extraordinary ethical questions that need research and need participation. The access to even access to the kinds of tests that my husband and I were fortunate enough to participate in. Who gets that? And how do we decide who gets that? And then when you face a crisis like COVID, we've recently faced enormous issues of how to manage allocation of scarce resources. And what is the role of cognitive impairment? And what is the role of caregiver dyads in those kinds of decisions? So we need people who know how to ask these questions, as well as people who know how to answer them. I would remind us that NIH Clinical Center has a terrific ethics department, chaired by Christine Grady, that does a lot and funds a lot of research in this area. And I hope that all of the research that we're talking about today, the new directions that we need to explore, will include the experts from many different cultural backgrounds, from many different disciplines, from different religious and secular points of view, and from intergenerational points of view, who can help shape the right ways to both ask these ethical questions and to answer the ethical questions. Thank you.
Thank you to each of our three research presenters. I'm pleased now to have the opportunity to present our two panelists for this session. We'll first hear from Michael Bellevue, who will share his perspective and insight in advocating on behalf of those living with dementia, including efforts to reduce stigmas associated with dementia. We'll then hear from Benoreen Brown-Boatswain, who's drawn on her career in higher education leadership in raising awareness about dementia in diverse communities, as well as among health practitioners. Each of our two panelists will speak for 5 minutes.
Hi, good afternoon. My name is Mike Belleville. I'm thrilled and honored to be here. I guess I don't have a slideshow, so you're kind of just stuck with me. So here I am. The things that I wanted to talk about today are when we're talking about technology and dementia, everything that Jared talked about is incredibly important, and the research and the things that are going to go into finding different technologies that are going to help people living with dementia live a better quality of life. My goal in that area is to try to help, and I'm actually working with a couple of different companies on developing technologies to be used with smart home technology, living in the home, to keep people living in the home longer. But the thing I would love for people to try to think about, or when you hear the word technology, technology is not just, wearing an Apple Watch, which I do because I have balance issues. Technology should also be thought of in ways of what we can do to reach out to people who have dementia, especially during these COVID times, to have a better, again, quality of life. And that's reaching out to them for social engagement. is what I'm trying to get to. So I was on a great call yesterday with some very smart individuals, and we were trying to come up with ways of what can we do to engage people with living with dementia to continue to stay engaged. And that's the key thing, is social engagement. I like to tell people that the #1 prescription doctor should be giving a person with dementia is not a pill, it's social engagement. I honestly believe that I'm still doing well with my diagnosis, and that just became 7 years just a few weeks ago. And that the reason for that is because I'm staying socially engaged. I volunteer at my local senior center, helping the senior population with technology issues. I do like to try to break down the stigmas of what people think about when they hear Alzheimer's or related dementias, and that although it may be struggling at times to learn something new, you can still learn something new after a diagnosis. I've learned to do a number of different things that might surprise a few people. So if I do anything but, drive the point home that technology is going to be a partner with any type of medication that is going to be hopefully found to help an individual live a better life. And I love that all 3 previous speakers all touched on different aspects. One of them was about how it's not just the caregiver and the person living with the disease. It involves the whole family. Dementia involves the whole family. So include the whole family. The other thing that I'll stress really important is that when we talk about experts in the dementia area, don't take this the wrong way, but I honestly believe that the experts are the people living with the disease. And if you really want to know what it's like or how it's going, talk to us. We want to be part of the solution. We want to be part of the process. We want to have a voice at the table. And thank you, NIA, for including all my previous friends who spoke earlier and myself and being included in this process. This is something that's very important to help reduce the stigma that people with dementia are automatically thought of as the latter progressions of the disease, and that nothing could be further from the truth. You can still live a meaningful, purposeful life. You can still contribute to society. You can still be a part of something. I'm just thrilled and honored that I can help do that in whatever way I can in the things that I love doing, and one of them is technology. So thank you very much.
Hello, my name is Venerine Brambooth-Swain. My journey with dementia started over 12 years ago when I served as caretaker for my husband of 37 years, Cedric Boatswain, whose journey ended on October 15, 2018, when he succumbed to the Alzheimer's disease. This experience as caretaking opened my eyes to the devastating impact of this disease and its impact on people of color. Many lives of caretakers of dementia patients are turned upside down. My journey involved not only navigating resources, but also constantly experiencing that many of the resources were not designed for my husband's experience as a Black man. I made a commitment after my husband's passing that I will focus on making the impact of dementia known in my community, as well as holding organizations accountable in providing inclusive and equitable services. Many think they are doing so, but in my experience, most have a long way to go. 2 years ago, I attended this conference, and one topic resonated with all the presenters for me. We need to engage communities of color more in our research trials. While today I hear questions being raised in terms of the impact on communities of color, I am wondering if we can go past the questions by getting results to the questions. For example, in the presentation on positive emotions, music have both a positive impact on people living with Alzheimer's and their caretakers. This is a proven and promising intervention. My question, however, is how are people of color brought into this engagement? My husband loved music and engaged in music right up to his death. However, the type of music being played in many of the settings he was in were not gospel, jazz, or calypso that are more familiar to him. My experience was my husband's lived experience did not seem to matter in some of these facilities, and the music was not comforting to me. Yes, music is good, but how does this music help a person build a sense of social capital if the music is not something they are familiar with? I don't know the answer. You may say, well, maybe I can do the research to find the answer. Well, maybe one day I will. My point is, when individuals of color are not engaged, we state that the findings is good for the people tested, so it's good for everyone. We can agree studies need to engage those hardest hit by dementia. We can agree that people of color are underrepresented in these studies, providing a gap in knowledge. We can also agree that a stronger and more trusting and transparent relationship needs to be built with communities of color to remove the barriers for participation in research. So how do we reach people? We reach them by meeting them where they are. And please don't wait until you need the research done to reach out. Be innovative in your recruitment, and it always helps to check your staff by asking, do the staff reflect the community you would like to engage? And if they are, don't assume that they are culture sensitive. I know this sounds simple, and some researchers are already doing this. Just a reminder that building a trusting and engaging community is hard work. It is my hope that 2 years from now, when the summit is held again, that we will find ways to connect, building and trusting and engaging with communities of color. So the research will hopefully lessen the current disparities.
Great. Well, thanks to each of our panelists and our presenters. We've had a number of questions that have been posted through the Q&A function. And so the first question is to Dr. Beng. How do we balance the promise of using technology to promote independence and safety with privacy concerns?
Yeah, it's a wonderful question, and I will not sit here and say I have the answer. I do think, though, that there are a few ways to start addressing that question. So first of all is working as researchers, working with technology experts and privacy experts to actually understand the implications ourselves of the data that we're collecting and the potential for breaches there. I think so in other words, clinical researchers, we're sensitive to things like patient identifiers and the HIPAA 18, but all of the additional data that comes with technology is something that we're not as well versed in. So we as researchers need to understand the problem better first. I think the second step is going to be learning the best ways to convey that sort of information. Once we understand the scope of the problem itself, being able to convey it to individuals living with dementia as well as their care partners to help them make an informed consent about what sort of data they want to disclose. My hope is with technology that we would be able to create systems where individuals could share the aspects of data they're most comfortable with, but be able to remove data that they may not be comfortable with. And in this way, maybe be able to more precisely hone the information that's gathered and for what purposes that it's used. Of course, it's not just the dynamic between the researcher and the individual participants in the study. It's also being able to convey that to external oversights like IRBs and data safety committees as well, so that we have external individuals looking at our approaches and our strategies to ensure that we're doing everything possible to protect and be sensitive to that data.
Great. I have a question I'll direct to Dr. Castle. And this relates to the implications for persons who are diagnosed or identified with dementia and on their families through before they have symptoms, either through genetic testing or as we're learning about, soon there will be blood tests. And what are the implications on these populations?
Well, I think there are many implications, and one of them is that some people will really want to have more and more of these tests, and we're seeing that already with the commercial genetic testing. But not everyone knows what to do with that information, and they may go to their doctor and say, well, what does this mean? And it has huge implications for how we train. That's why I mentioned the primary care providers and giving people the tools so that they can effectively answer those questions for patients. And I think the other thing is how we deal with uncertainty, because as you know, all of these tests are probabilistic and also may unfold, as we heard from Michael, may unfold over many years ahead. And so wanting to make sure that there's not misinformation or misassumptions, particularly in the background of communities of stigma, that may have a very negative effect on people if they get the test done or then decide not to disclose it. Remember, we live in a world of fake news now, and all kinds of misinformation becomes very widespread very easily. So we want to make sure that when we have new kinds of diagnostic markers, that we are able to actually share the information in ways that are positive and not risky.
So the next question is for Dr. Monin. And there was a question about whether emotions tend to be grouped into mental health outcomes and possibilities for better differentiating between the two.
Yeah, so actually emotions as an outcome is often separated from mental health outcomes. So usually people focus on clinical measures such as depression or caregiver burden or anxiety or things like that. But a lot of positive emotional experiences, for instance, are mixed or complex emotions, or cultural types of emotions are mixed in a lot of those measures. So it's going to be really important to see how those emotion measures kind of map onto the clinical measures that clinicians are used to see what those kind of clinical implications are, but also to move beyond that to more of a positive quality of life way of looking at measures.
Okay, we have another question here on stigma. And what do we know about the research on stigma? What has been found? What areas still need to be discovered?
Well, I can begin that because I raised it in my comments, but everyone else used the word in their presentation. We assume that these things go hand in hand. And the reason I raised the Robert Butler example is that, when Butler founded NIA, we called it senility. And there was a thinking at the time, and there was people didn't want they kept people in their households. They didn't tell their even neighbors what was going on because there was great stigma about senility. Butler thought, if we understand, we do more research, we understand this brain disease or number of different kinds of diseases, and make it a medical condition, then it won't have the stigma. And I think, unfortunately, it wasn't that simple. Even though we do understand this as a medical condition now, there still are social inhibitions about how to continue to include people who have cognitive impairment in community activities. As we just heard how important it is to stay active, to stay engaged. Some communities will welcome that, but lots are still uncomfortable about it. So I'm arguing that this should be close to the top of our list for social scientists as well as others, even political science, to look at how do communities change their points of view about conditions like this. And then we can understand what kinds of, is it education, is it activism, what is it that could help to reduce stigma.
So the next question, there's two questions for the Noreen. One is building on the question about culturally sensitive strategies to address emotions. And there was also a question from some asking about how to encourage African Americans in research, that this person has said that they found this very challenging in their work.
I think often that what my experience have been that research is, individuals, especially African Americans, are invited into research right when the research needs to be done. There is no trust within that area because you're being invited in with a group that you probably do not know. We need to begin to engage with individuals very early, be in communities, learning more about communities, meeting people in communities, having relationship with individuals with communities. For example, I have a support group, and the support group does have some distrust about the medical field and research. So what did I do? I invited someone that do a lot of research to come in and speak to the individuals about that research that they're doing, how they go about inviting individuals with research, and beginning that trusting relationship with that person. So if that person comes back, individuals know them. They already are trusting them. They've already built a relationship. So when this person reach out and say, I would like for you to be in my research, they understand what research is about. They already have a trusting relationship with him and his group. So they know, and they will begin to be more engaged with it. But I think often what happens is that we wait till the last minute. We may have one person that we know, and then we want to just engage individuals.
So I'll bring up one final question that was raised from the audience, and this has to do with, it's in the setting of COVID-19, but it's really applicable beyond the COVID-19. You know, we're in a situation now where many of the places where persons living with dementia socially connect, senior centers, adult day health programs, these are not available. So what is the backup? You know, what is the alternative? You know, in a situation where these in-person events and convening, it's not possible.
Jared has the answer.
Go ahead, Jared.
Yeah, I'd love to hear Mike's thoughts on this as well, since he's living with this. I will say I've been so proud of our local communities here for For example, I go and speak at our local Parkinson support groups. They have gone all virtual, and it is an amazing opportunity to do seminars much like this with our local support groups, see the local individuals because of the gift of video conferencing and people going and dropping off spare devices to people who may not have them so that they're able to access this. It's not perfect, but there's potential here, but with all the same problems of any other technological intervention. So technology, I think that's my job to cheerlead that, is a potential. But Mike, I was curious what your experience has been.
Sure, absolutely. I'll be honest with you, when this first started, people asked, how you doing? Has everything going okay? And I was like, in the beginning, and no offense, but I was like, welcome to my world. I mean, the way people are living now is the way most people, sadly, are living with dementia. And that's, some of them are secluded. They don't have access to a lot of different things. They're stuck indoors. They can't get out. And I like to joke and tell people we were using, we've been Zooming when Zooming wasn't cool. Okay, we've been doing this for years with the number of different support groups. But to answer the question, and I'll put a little plug for an organization I'm involved with called Dementia Action Alliance. We were just on a call yesterday. That call I said I was on with all those smart people was to tackle this exact problem or this exact issue. And that's going to be done through collaboration with, hopefully, our senior centers, with different organizations, with people who have already successfully done it locally, and we can try to expand that out more regionally and then hopefully nationally to different people. But I mean, as you hit the nail on the head, Jared, when you said if we can get technology in front of people, and there's programs out there where people can donate their old cell phones or their old iPads. Just because it's a cell phone doesn't mean you don't have to use it as a cell phone. You can still connect to Wi-Fi and use it in that way. And there's a number of different programs out there where you can go to do that. So the way we've been doing it is the way we've been doing it for the last, since I've been connected with these folks for the last 4 or 5 years. And that's using technology just like this. I hope that answers the question.
Thank you. And thanks to our presenters and our panelists for getting us off to such a great start for the first panel of our third meeting. It's now time for a 10-minute break. And I believe we will be asked to be back at, is it 2:40? And once we transition to the break, the time back will be posted on the slide. And we'll be coming back to hear from the co-chairs from Theme 5.
Testing 1, 2, 3.
If you haven't pinned the timer and you are a panelist, please do so now. While the timer is visible, please right-click on the timer and select Pin Timer.
It's now 2:40. I'm pleased to welcome the audience back to our second panel of the National Research Summit on Dementia Care Services and Supports. And I'm pleased to turn over the mic to the theme co-chairs, Michael Monson and Malaz Bustani.
Thank you so much for inviting us to organize and coordinate this, exciting next hour. I want to introduce the theme and also introduce my partner in crime, Mr. Michael Monson, and who is the senior VP of in one of the Centene organization, and has this amazing experience in implementing a model of care in the real world. What you will hear from us in the panel, perspective on the science of discovering scalable and sustainable solution, the science of implementing such solution, and the science of diffusing such solution. Let me introduce the three amazing panelists for you. I'll start with Dr. Jürgen Unitzer, who is the chair of the professor and chair of the Department of Psychiatry and Behavioral Science, and the director of Carvey Institute for Brain Health Solution at University of Washington. He will be followed by Dr. Lucy Lycum from South Texas Veteran Healthcare System and Dell Medical School in University of Texas at Austin. And they will end with Dr. Elizabeth McLean, who is the vice president at Kaiser Permanente Research and the interim senior associate dean for research and scholarship at Kaiser Permanente School of Medicine. So please welcome, and I'll hand it over to Dr. Unitzer.
Well, good afternoon. Thank you for the nice introduction. I'm going to talk a little bit about something we haven't said too much about, that is not dementia, but depression. And I'm talking about how we develop, and then more importantly, how we actually implement an evidence-based model of care in practice. Next slide, please. Little disclosure, my day job is I chair the Department of Psychiatry at the University of Washington. I do grant and contract funded work on integrating mental health and primary care services. I don't do any paid work for pharmaceutical or device manufacturers. Next slide, please. So depression is a very common problem in older adults. About 5 to 10% of people sitting in a primary care provider's waiting room on any given day have clinically diagnosable significant depression. And this turns now out to be the single largest driver of health-related disability in the world. And it's not just feeling down, having a bad day. This is a truly miserable state that can last for months or even years. It's particularly chronic in older adults. Next slide, please. How good is current depression care? So I'm a geriatric psychiatrist, and I would say that fewer than 2 out of 10 older adults who live with a serious clinical depression will ever see a psychiatrist, a psychologist, or any other healthcare provider who has specific training to treat something like depression in an older person. Well over half, at least half of all older adults who have depression do receive some treatment for their condition in primary care. When you look at what happens in primary care for older adults with depression, I'm a glasses half full person, and that is a lot of primary care providers are now sensitive to the fact that their older patients could have depression, but they have limited time and means to deal with that. There was a wonderful study now a little over a decade ago in JAGS that said that the average primary care visit where a primary care provider tries to help an older person with depression, they have about 2 minutes to devote to that. And I'm a very good clinician, but I couldn't diagnose or fix depression in a 2-minute mental health visit. The one thing we do in this country is we like to give people pills. So there are about 4 or 5 million older adults who walk out of a doctor's office with a prescription for an antidepressant medication every year. But if you follow that, those 4 or 5 million people, only about 1 in 5 will have significant improvement. Very few of them will get other kinds of effective treatments, such as counseling or psychotherapy. Next slide, please. Our primary care colleagues know this. This is from a survey. 2/3 of all primary care providers around the country, 60 US communities, who were asked about access to consultation for their patients, said our access to mental health services for our patients is terrible. Next slide, please. So what do we do about this? How do we get more older adults with depression effective treatment? Next slide, please. So about 2 decades ago, some of my colleagues and I set out to solve this problem. And we developed a primary care-based approach to treating depression called collaborative care, or the impact model that is now strongly evidence-based. And the concept is pretty simple. We say we start with the primary care physician and the patient, and we supplement, we augment that team in primary care with a mental health care manager and a psychiatrist who can consult to that team if they're having particularly challenging problems. We also put in some specific processes of care. So every time a patient comes in, they get their depression measured with a tool called the PHQ-9, just like you would measure someone's blood pressure if you're treating hypertension. We teach the staff in the clinic some very brief, effective behavioral strategies for treating a person with depression. We track all patients in a registry so people don't fall through the crack. And we have access to a psychiatrist who can systematically review and make suggestions on every patient seen in primary care who's not improving. That's the model. Next slide. How well does this work? This is from our main study findings. So we tested this with 2,000 patients in 8 healthcare organizations in 5 states in a large randomized controlled trial. And the bottom line is that this kind of an organized collaborative intervention more than doubles the likelihood that people's depression will be significantly improved 12 months later. Next slide, please. Chris Callahan, a colleague who was on the team, also published that not only did people's depression get better, we also saw significant improvements in their physical functioning. So doing right by depression isn't just good for your emotions and your mood, it also helps your physical functioning and also your social functioning. Next slide. So that's all great. The final piece of evidence that we produced as part of the research was the fact that when we looked several years out at total healthcare spending for this group of about 2,000 older adults, most of whom were on Medicare, we found that the people who had gotten this collaborative intervention for depression not only had better health outcomes, we saw significant reductions in total healthcare costs. For every dollar we spent on this intervention, we saw about $6.50 in healthcare cost savings. So next slide, please. So this was kind of like a home run from a perspective of a researcher. So we were able to show that we came up with a better way of treating depression in older adults that fits into typical primary care settings, and it not only improves health, it actually reduces healthcare costs. This was sort of the quadruple aim of healthcare reform, although I don't think Donald Berwick had spoken that term yet when we were doing this research. Next slide. So this is all great. We have a strongly evidence-based intervention. It works. It worked in a lot of different settings. It worked for African-American elders. It worked for Latinos. It worked for whites. We were quite pleased with this. And then we embarked on a 15-year journey to try to help organizations actually implement this. So I'll conclude with a few comments on that experience. We developed a program called the AIM Center that is not doing more research, but its primary mission is to help disseminate this evidence-based intervention. And we have to date trained a little over 5,000 clinicians in now well over 1,000 primary care clinics around the country in implementing this intervention. We've written some manuals. We've produced a lot of video, a whole bunch of materials that help organizations who really are motivated by the evidence to try to implement this. The most important, part of this has been is what's on the bottom of this slide. We had to find a way for Medicare and other payers to pay for this, because if you can't get paid for it, nobody is going to do it. We spent a lot of effort and time working with the American Psychiatric Association and CMS, and developed a bunch of CPT billing codes that primary care practices can use to charge for delivering an evidence-based course of care called collaborative care. Next slide, please. We also realized that this is new type of work. This is a teamwork, a team approach that most psychiatrists are not trained to do. So we had a 4-year project funded by CMS in partnership with the American Psychiatric Association, where we trained over 3,000 psychiatrists in every single state of the country in providing the kind of psychiatric consultation that is really effective in a project like this, in an effort like this. Next slide, please. We set up in our state here in Washington a system where we implemented this kind of a program in partnership with a managed Medicaid plan, where we went into over 100 primary care clinics and said, let us help you track, using this evidence-based model, what is now a little over 50,000 patients with depression. And we have psychiatric consultation provided into all of these clinics, tracking all of these patients on a piece of registry software and showing that we can really improve outcomes, not just in research. Next slide, please. So when we look back 10 years, we have now implemented in a lot of clinics. This is a slide from a study that's about to be published, where we've looked at the average response rates in about 130 clinics that have implemented this model of care. And what we see is, on average, we get outcomes that are fairly similar to the original research. Not quite as good, but not too bad. But there is a huge distribution across these 130 clinics that we work with and how well this is working. Next slide, please. And what we find is that clinics where our team has given a substantial implementation support actually do much better than those who just took the evidence and said, we'll do this on our own. Next slide, please. We also found that when you pay for performance, this is a slide based on a study with over 6,000 patients, you can dramatically improve the quality of implementation of a program like this and the ultimate outcome. So this is published a couple of years ago in the American Journal of Public Health. And now I think my last slide. So some of the lessons, research evidence was incredibly helpful, but not sufficient. Money matters. If we couldn't find a way for people to get this paid, they won't do it. Demand is important. When we started this work, nobody was asking us for this, and we have spent since a lot of time trying to create a demand for this kind of an intervention. And then finally, it makes a difference if you provide good implementation support. Let's finish up on this. Thank you.
Thank you very much, Jürgen. We'll hand it over to Lucy or Dr. Lykim.
Thank you all for the opportunity to speak with you today about challenges in implementation science as they relate to the care of persons living with dementia. Next slide. I have no disclosures. Next slide. I'm going to be talking about implementation science, which is the study of methods and strategies to take things that work in research trials and put them into routine care, just like what we just heard about. So for example, if there's a new treatment, how do we make sure that everyone who should get it actually gets it? If there's a new support program for caregivers, how do we make it widely available across many different types of settings? Implementation is the process of putting evidence-based interventions into regular use so that we close the gap between what we know we should do based on evidence and what we actually do in routine practice. Just some quick definitions. When I talk about implementing an intervention, that intervention could be a number of different things, from a new medication to a best practice to a new support program. And participants could be individual persons living with dementia or their caregivers, or they could be clinicians or even healthcare systems. Next slide. Unfortunately, our ability to implement things that work has been limited when it comes to dementia care. And there are 3 key reasons that I'll talk about today. First, our evidence base for effective treatments is limited. We need more information about treatments and interventions that work. Second, often people don't want to accept services that might be beneficial, which limits our ability to put those services into routine care. And finally, we're trying to take things that work in one type of place and put them into practice in other types of places, which often makes things work less well. Next slide. So we'll talk about each of these challenges and how the field of implementation science is trying to overcome them so that more people have access to effective treatments and programs. Next slide. So let's start with the issue of needing more evidence-based interventions to be able to implement. If we wait for our knowledge of effective treatments to expand before we then try to understand how to put those interventions into routine practice, we'll be waiting a really long time, too long. This is where hybrid studies come into play. In hybrid studies, we're doing two things at the same time. First, seeing if the intervention works, what's called clinical effectiveness, and second, seeing how best to implement it. There are three different types of hybrid studies which differ in how much emphasis they put on assessing the intervention effectiveness versus studying the implementation. But by studying the effectiveness and implementation at the same time, all hybrid study designs can help us put effective interventions into routine practice more quickly. Next slide. There are some other types of study designs that are being used more frequently to help us test interventions and how best to implement them. One is a stepped wedge design. So rather than the traditional randomized controlled trial approach of seeing if something works, in which half the participants get an intervention and half don't, in a stepped wedge study, all participants are given the intervention in a staggered fashion, as you can see here. This has some benefits. First, it allows us to see the effect of the intervention when we implement it, and it also allows us to go back and see what happens to participants after that immediate implementation period. That way we can see if participants stop using the intervention or if they start using it differently, which is important information. Second, all participants have the potential benefit of getting the intervention rather than potentially getting no intervention at all. Click. Another type of useful implementation study design is something called a SMART design. So rather than implementing something for an entire study period, seeing how it worked, and then seeing how to improve it, in a SMART design, study participants have the opportunity to tailor the intervention along the way through assessing interim outcomes and adjusting the intervention to make it work better if needed. By continuing to develop new study designs, we can more rapidly expand our knowledge base regarding effective interventions and how to put them into practice as quickly as possible. Next slide. Next, we move to the issue of persons living with dementia or their caregivers not accepting interventions or services. So why might people not accept things that should help them? On some level, those services must not meet people's needs. If we want to increase intervention uptake, one vital way of doing this is to partner with patients, caregivers, and clinicians from the beginning to design the types of treatments, services, and interventions that they would find most useful. Next slide. A key strategy for accomplishing this type of partnership is through using what are called participatory approaches. In these approaches, researchers collaborate as equals with patients, caregivers, and others to co-create interventions that best meet participants' needs. This allows for the development of interventions that are best matched with recipients' real-life challenges, care gaps, and experiences. Next slide. An important consideration as we work more and more closely with caregivers is being very clear on their role in this work. Click. We ask a lot of caregivers. We ask them to participate with us in research studies. Click. We ask them to be informants, to report on themselves and how they're doing. Click. We ask them to be proxies for the people for whom they're caring. Click. And we ask them to partner with us in actually delivering the care. It can be very difficult for caregivers to balance these multiple identities. And as we develop more participatory approaches, we have to do so in a way that is mindful. Next slide. An example of a participatory approach that is getting a lot of attention is design thinking. Design thinking is different in that it starts with the participant's experience rather than with a set of outcomes that is defined by researchers. Through empathizing, researchers work with participants to understand the unmet needs and participants' lived experiences. They then try to define gaps and problems based on those unmet needs and ideate to create potential solutions. These solutions are developed into prototypes that can be tested to see how effective they are in meeting needs and closing gaps. So design thinking not only asks people to be involved in developing the solution, but also in defining the problem on their own terms. Next slide. Now for our third challenge, taking things that work in one place and putting them successfully into practice in other places that are often very different. Next slide. As we think about this challenge, these are the types of questions that we're asking in implementation science. First, what is the essence of the intervention that really matters? So for example, if we're trying to implement an effective caregiver training program across multiple sites, we might ask, how much do we need to adapt that training to meet the needs of different types of caregivers? Really understanding the critical components of the intervention that make the difference is vital. Click. Similarly, what are the important features of this context that we have to take into account? For example, how does a care pathway get implemented differently in a rural versus suburban setting, or solo versus large group practice? Click. And finally, how do the intervention and the context interact with each other? Can we try and align these so that they are more likely to be reinforcing? Next slide. I put this slide with the flock of birds in because it illustrates this challenge. Birds have rules of how they interact and fly that are so implicit to them that they do it naturally. And for us watching from the outside, if we wanted to get them flying in another direction, we would be hard pressed to do it in a controlled or predictable way. And it's the same with trying to change care delivery. Changing the way people have organized themselves to do the work is a hard task, even if they know they can do better and want to change. Next slide. So how do we take local ways of organizing work into account so that we implement new interventions in the most effective way? So here's one example used in implementation science called replicating effective interventions. We start by understanding the preconditions. What do people in a specific setting think of the problem in the intervention? Click. We then engage people in planning for success. How exactly are they going to put the intervention into place in a way that will work in their context? Click. During the implementation period, ongoing feedback is provided so that people can see how they're doing, adapt what they're doing, and continue to improve. Click. And finally, in the maintenance phase, those refinements and adaptations continue over time in an active, dynamic, iterative process. Next slide. So to summarize, we've talked about the challenges we have in implementing interventions to improve the care of persons living with dementia. As always, our challenges represent opportunities, and new approaches in implementation science will improve our ability to put evidence-based interventions into routine care for the greatest number of people in the shortest amount of time. Click twice. We're using adaptive interventions that allow us to best meet the needs of patients, caregivers, and clinicians in each local context where care is delivered. Click twice. We're using participatory, human-centered design thinking approaches to partner with patients living with dementia and their caregivers to co-create interventions that are most relevant to them. Click twice. And finally, we're developing approaches to study things over time, such as smart, adaptive step wedge designs, so that we understand the long-term impacts of interventions and how to maintain them. Thank you so much.
Thank you so much, Lucy. Now let's move on to Dr. McGlynn, and she will share her experience about learning healthcare system.
Thanks so much, Malaz, and I'm delighted to be here today to talk about learning health systems at this conference. Next slide, please. And I'll say, I noticed that my disclosure slide went missing, but I don't have any disclosures. Click. This definition of learning health systems comes from the Institute of Medicine. And essentially it is, a learning health system is a system in which the science, informatics, incentives, and culture are aligned for continuous improvement and innovation. And what that allows is for best practices to be embedded into care delivery processes. This says seamlessly, that's obviously an ideal, but that's kind of the goal that these systems are going for. And that new knowledge is captured as a byproduct of the delivery experience itself. And I think the simplest way to think about it is, if you think about the illustrations that Jürgen and Lucy have just given you, it's systems that are able to do the kinds of things that they're talking about on a routine basis. Next slide. I use this model of the learning health system, just the picture, because I think it's helpful. If you click, it starts with the data, and data become very important as the coin of the realm. It's what the system ingests to try to understand what's going on. Click. That data allow opportunities for research to be done to generate evidence and to try to be responsive to an ongoing set of questions that are coming up. Click. When we learn about best practices from these mechanisms, these can be fed into point of interaction tools that allow the right information to be displayed at the point of care, enabling more routine and reliable delivery of best practices. And then click. The final step is ongoing monitoring and analytics. Some of what Lucy was talking about when you move into new locations or you add elements, you really do need to keep looking and learning so that you can understand what's going on. I'm going to talk about each of these 4 elements in a little bit more detail. Next slide. So most learning health systems have data that they're ingesting from lots of different sources, and the data themselves are quite variable and come from a variety of different sources and increasingly include members, patients, and their caregivers. There's a need to usually curate those data so that they can be used effectively in outputs such as registries, which I'll talk about in a minute. Next slide. So the data that are available are actually quite helpful for things like activities to prevent the development or lower the risk of the onset of dementia and Alzheimer's. This is a list from the Lancet Commission's review in 2017 of some of the evidence-based interventions for reducing risk. And these are all typically readily available in these kinds of health systems. Next slide. Some of the opportunities that are related to data are the creation of registries, and Jürgen talked about this and I think gave a really nice illustration, but a lot of the progress we've seen in chronic disease has come from creating these registries, and the registries can be used both to facilitate research and to more rapidly be able to reach out to the population of people who could benefit from new insights. So I think these can be terribly important. We need to look at opportunities for collecting new data, and this has come up in both the prior session and our session, and in particular thinking about collecting data from the patient experience and from caregivers. And then I think there is an opportunity to take advantage of the growing interest in social needs, this connection between the traditional healthcare systems and the much broader community and social services areas are important. And I'll give an example in a minute. So go to the next slide. So that was all about data. Now, learning health systems can also generate different types of evidence. If you click, there's the RCTs that we're very familiar with. And we saw an example in the prior session about having not enough RCTs in some of the spaces we're interested in. But they are particularly helpful for CLIC, understanding something about what works in the real world. And so we've talked in these sessions about pragmatic trials and observational studies. And Dr. Monin gave some examples of this previously. And then CLIC, the learning health systems also are particularly important for the kind of thing Lucy was talking about, implementation science and quality improvement. So these are some of the kinds of research methods that can be used in learning health systems. Next slide. And I often like to make the point that research quality evidence is often needed across the board. It starts with even in areas where we think we know what to do and the evidence isn't changing much, there is quite an opportunity for monitoring for reliable execution and to improve the efficiency with which things are done. And then that goes all the way up to the state of current knowledge where honestly we don't have any idea what to do when we're in the world of exploratory research, interest in things like artificial intelligence and machine learning areas, and then everything in between. Next slide. So I think, one of the things that I think is really an important opportunity, which takes advantage of the renewed focus on social determinants or social factors that contribute to health, which are important in lots of different domains, is to look at things like, this is just an example from our own system called Thrive Local, where we have partnered in our communities to create resource directories in the community, a network of organizations that are able to do bidirectional communications. We can provide referrals to those organizations, and we can learn whether those connections are working, and all within a secure IT system. These new ways to bring social determinants actively into care delivery need to be evaluated. We need to see if they're going to work, but I think they're really promising. Next slide. So that's a little bit about data and research now. I'll just say quickly that the point of care tools, which are really integrated into workflows, and Jürgen talked a lot about this, that enable more accurate diagnoses to be made, needs assessments to be done, referrals to be made, but are done within the context of regular care delivery, can be terribly important for improving best practices. It puts the right information in front of really a variety of people on a team and can make doing the right thing much easier. It can facilitate action through prompts and reminders, but it needs to be presented in a way that's easy to use. And it may be a way to drive scalability and sustainability. If you go to the next slide. So then the fourth element in that wheel is ongoing monitoring and analytics. So in looking at some of the things that look most promising in the area of treatment for persons with Alzheimer's and dementia, a lot of those interventions are multi-component and very complex. And they get even more complex if they take seriously tailoring to individual needs. And we've heard some about that in prior sessions. And so ongoing monitoring of how these models are implemented in different places with different contexts, what adjustments are being made over time and what barriers are being encountered is really critically important to understanding the outcomes that you might expect to get from those models. And I think one of the challenges, and I think Lucy talked about this really, I think quite helpfully, is to do this in a way where you make changes systematically and intentionally so that you can learn from them. If the changes are going on and you can't really capture them, you don't know when you begin seeing either more or less effective implementation, kind of the example from Jürgen on depression care, what exactly caused that? So you need to be able to figure out what has contributed to the outcomes that you're observing. And there are a variety of tools that get used in systems, dashboards, pairing quantitative and qualitative assessment, tracking long-term outcomes. All of these can contribute to an understanding and ongoing assessment. So next slide. So just a little bit of concluding thoughts. I think learning health systems are a very valuable enterprise for advancing real-world systems for delivering best-in-class care for persons with dementia and Alzheimer's. I think too, and I wrote challenges here, but you really could think of them as opportunities, are developing systematic approaches for engaging, creating engagements between medical and non-medical systems. And really, I think we've heard a lot about, and this, I think this whole summit has been about engaging family and caregiver perspectives in ways that we have not done at scale as effectively as we should. It's tempting to think about putting systems of systems together. I'll say that those have been challenging to do effectively, but it may be worth continuing to look at that. And we need to look for opportunities to engage with related efforts. That is, not to have to go it all alone, but to look for chances to pair up with other areas that are trying to accomplish some of these same goals. So thank you.
Thank you so much. So now what we're gonna try to do next? Can you advance the slide, please? Yeah. So what Michael and I are gonna do, we're gonna share with you the 10 research opportunities that our panel have identified. I'm gonna read the first 5, and then Michael will read the next 5. So the first one is identify contextual and structural feature that would be needed to create a learning laboratory to catalyze interactions, collaboration, and coordination of interdisciplinary team and organization to shorten the translation of innovative Alzheimer's disease-related dementia care services into widespread use. Next, identify factors that create market demand and promote availability of evidence-based tools for the rapid implementation and diffusion of the collaborative care models within various payment models. Next, develop and evaluate tools, processes, and strategy to incorporate AD-focused intervention strategy into the current and future workflow of the busy primary care system. Next, develop and evaluate evidence-based tools, processes, and strategy for the most optimal integration of AD care services across healthcare delivery and community-based organization in rural and urban setting. Next, leverage advances in health information technology and network science to develop tools, processes, and strategies to train, support, and involve family and other caregivers in the care of person living with Alzheimer's disease and other related dementia. Michael, next.
Thank you, Malaz. So the sixth opportunity is to conduct research to develop and study mechanisms to financially compensate family and other unpaid caregivers of persons living with Alzheimer's disease and related dementia when they play essential roles in implementing the care plan of those individuals. Next slide, please. The seventh one is around conducting research to understand the effects and strategies to financially compensate community-based organizations, as we just heard from the last speaker, that have essential roles in the care of persons living with Alzheimer's disease and related dementia. Next. To study how principles of agile design, which we also heard during this presentation, in the last prior presentation, implementation and diffusion that integrate science and engineering and can promote dissemination of care innovations for people living with Alzheimer's disease and related dementia. Next. Develop and evaluate network science tools, processes, and strategies for disseminating evidence-based models of care in rural areas and within and between demographically diverse populations. And finally, develop scalable, sustainable, and actionable care interventions that payers and providers can use off the shelf in practice to improve quality, safety, and financial return on investment with guidelines on how to implement the intervention, including key contextual factors.
Thank you so much, Michael. Now we're gonna move on to our discussant, Dr. Linda Onken, and she will have a reflection on what we heard so far. Lisa, it's all yours.
Thank you. I'm honored to be included among the distinguished speakers at this summit. And what I'd like to do is just try to highlight a few of the excellent points made by the speakers and maybe integrate a few of these points. So Dr. Bustani emphasized developing scalable, sustainable, and actionable interventions that can be used off the shelf with guidelines on how to implement the intervention and key contextual factors. So if we can't sustain an intervention, we can't successfully implement an intervention. Dr. Lakem discussed the importance of replicating efficacious interventions. She asked, what's the minimum required intervention, right? She also stressed the critical contextual factors and the interactions between them. So if we can't replicate, we can't implement successfully. Dr. McGlynn asked what works in controlled studies. If we can't reliably do what works, we can't implement. And Dr. Unitzer couldn't have said more clearly, implementation is one of the valleys of deaths, as I recall from his last slide. So next slide, please. We all know that interventions can be complex and difficult to learn, and that's a lot of what makes them difficult to deliver with replicability and reliability. Next slide. So if we're trying to cook a meal, if we're trying to follow a recipe, it does help to know the main ingredients, the essential ingredients. For a lemon cake, we know we need to have lemons, but if we make a lemon cake with lemons and flour and baking soda, but we don't include any sugar, we're not going to make a very good lemon cake. I don't think we'd make a cake at all, and people certainly wouldn't want to eat it. If we put chocolate in the lemon cake, it won't taste like a lemon cake. It won't taste very good if it has lemon and chocolate, most likely. We need to understand that the cake requires baking soda. Similarly, for complex behavioral interventions, we need to know what to do, but we also need what not to do and why not. We need to know the essential ingredients. And if we don't know the essential ingredients and why they're important, just like it would be hard to recreate a recipe, with behavioral interventions, it would be hard to replicate the intervention and deliver it correctly without knowing the main ingredients. Next slide. So what's so hard about delivering interventions with fidelity? Well, even if we had a 3-star Michelin chef teach us how to make something, not everyone will be able to learn how to make the dish the same way it tasted in the restaurant. Not everyone has the same background and experience, and even when people do learn, not everyone will remember how to recreate the recipe next week or in 2 weeks or 2 months later. The same is true when we teach people how to administer complex behavioral interventions that need to go into complex service delivery systems, perhaps. So what can we do about this? Well, I'm just throwing out a few thoughts for your consideration. We can, for one, as many of our speakers pointed out, recognize the importance to ultimate implementation of an intervention of knowing the essential ingredients of the intervention and how and why an intervention works. We can also consider the ease of implementability of the intervention as early and as often as possible in the intervention development process. And this includes involving stakeholders as necessary early in the process and as often as needed in the process, and taking into account the key contextual factors that affect implementability. And finally, we can recognize the importance of developing and modifying explicit training procedures for complex behavioral interventions, and the importance of rendering these training procedures as scalable as the interventions themselves, and testing these training procedures with the same degree of rigor that we test the interventions themselves, to ensure that when interventions are delivered in the community, they can be delivered with sustained fidelity. So just a few thoughts for you to consider. Thanks very much for your time and for your attention.
Thank you so much, Lisa. I think I will hand it over back to David and Jennifer for the Q&A, and I'll try to direct the questions to the right panelist.
Great. Thank you very much to all the panelists. I think the first question goes, well, you can direct it, but it probably goes to Dr. Unitzer, about older participants who have dementia being treated with antidepressant, even though they're not diagnosed with depression, and maybe comment a little bit how that interferes with studies of Alzheimer's and other dementia.
Okay, let me try to take that. So unfortunately, the real world is complex. People don't just have the thing we want to study. Depression and dementia often occur together. There are a lot of people who have dementia who will develop depression, maybe in part because it's difficult, especially in the early stages, to live with a dementing illness. There are people who have late light depression that may really be an early presentation of developing dementia. It's not easy to sort it out. There are good tools that we can use in research and in clinical to try to differentiate depression and dementia, or to diagnose both concurrently. In terms of antidepressants being used in this population, I would say, just like in any population, the most challenging thing is to make sure that if they're not working, we stop them. Because I see a lot of patients who get started on an antidepressant and they take that for the next year or two, and it never worked in the first place. So I think that, like with any other intervention, it could be helpful, but if it's not helpful, let's stop it and try something else.
Thank you. So the next question actually came from a couple of questions. The first has to do with improving replicability across dementia care studies. And just to expand a little bit on that, is in implementation science, how do you balance pragmatism versus fidelity in terms of making sure that in replication studies and dissemination studies, that people are really receiving the interventions that have been demonstrated to be effective?
Okay, thank you. Lucy, can you take this and I can add some input on that?
Sure. So, I personally come down on the side of pragmatism, and I really wonder, is our goal to replicate or is our goal to improve? And if our goal is improve, we can, be a little adaptive in how we get there. But there are some things that I think we can do. So first, really understanding the context. If we try and understand the key contextual factors when we start, those will help us think about how those contextual factors are similar or different to the other organizations in which we're going to try and work. And they can give us some clues to how to proceed. And the other thing I think is critically important is a continuous ongoing assessment as we implement, because that's part of what tells us what are the key factors of this intervention that's working. What is really resonating with people? What are the parts of practice that are changing? And how do we assess those outcomes to know what's changing over time? Those will give us the pieces of information that we need to then continue to implement in other places. Malaz, I'm curious to hear what you think.
Well, I think the question, David, might be relatively not relevant. And I hate to say that word because in the real world, the problem is not, am I implementing solution? The problem is my problem going away? Is my PHQ-9 is going away? So when you end up focusing on problem solving, the original problem, that gives you a lot of flexibility to take into account contextual pieces and taking into account flexibility to update evidence-based solution. So Jürgen, for example, when he took the impact and he can help, he made sure in the implementation there's something called PHQ-9, which was making sure at the end of the day, these patients who have depression, their depression went down, and he had a lot of flexibility to change the problem-solving strategy that he tested, the antidepressant, the new one or not. So focusing on an outcome measure for the problem, and then secondary outcome measure for process, that might help in that transition and replicability.
Okay, another couple of questions came in about learning health systems. And one of the questions came in about how do health systems, learning health systems deal with data that aren't usually collected in the electronic health record, such as patient identified and prioritized goals of dementia care, and how do they use stories? Stories, because everybody who has living with dementia has their own story. So just get a comment on that.
Elizabeth?
I'm sure I'll start. I'll start with the first question or the last question first. And I think Lucy gave a great example of that, which is the increased use of design thinking to develop interventions. And that's actually a place where stories and priorities can become really important in even thinking about what interventions or systems that you're going to try to put in place to accomplish the goals of care. So that's, I think that's a critically important thing. And I think there's more and more of that going. I think the second thing in terms of taking in different kinds of data than have typically been used in electronic health, we talk about sort of like the data ecosystem that we use. And there is an opportunity to bring together really very different kinds of information. And we've done this with patient-reported outcomes, and to create views that get integrated into more traditional provider-facing tools, clinician-facing tools, so that information that includes things like priorities or includes things about preferences, includes things about the individual, can come up at the point of care and to integrate the information. So I think we're already seeing areas where this has been done, and it does require investments in technology and really learning what's going to work the best. But I think there's a lot of potential for using those systems to individualize care delivery in the ways that the question suggests are important.
Right. So another question, I guess this was once again going to Beth, is what is actually motivating the focus on integrating social factors at the point of care? And how does this relate to dementia care?
So I'll probably be a little bit more versed in saying what's motivating the interest. I think the interest is motivated by my simple response to that is usually Maslow is right. If you actually cannot, if people don't have their basic needs met, housing, food, a safe environment, you know, other things that have to do with meeting people's basic needs, it's pretty hard for any kind of even excellent healthcare system to make a dent in people's health. So I think to the extent that systems are focused and interested in optimizing health for the people they serve, you can no longer ignore the importance of those other factors. So I think that's where the motivation comes from. And from my perspective, for people who have dementias and Alzheimer's disease, you know, this is in some ways as important as we know it is for people with any kind of chronic long-standing disease. So I think it's just, if you really want to make a difference in health, and I work in a system that wants to make a difference in health, you just can't ignore these factors anymore. And I think we've had evidence about that for a long time, but it's getting harder and harder to walk away from the need to pay attention to those factors.
Another question just came in on the needs for investment in data and technology. Obviously, large healthcare systems can do this. Smaller healthcare systems, private practices, community-based organizations, this is much more difficult. So what does it take, and how can this be accomplished?
So let me take this one, and then I'll end up asking Jürgen, because he had to work with much more diverse piece. I think the question has really amazing emphasis that small practices, rural practices may not have the capability. So one option we've been doing with support with CMS is creating this concept of collaborative or network, where you actually hedge the cost across all the memberships of a network and manage that need instead of not having these resources. But I wonder, Jürgen, if you can say how's the simple data requirement that had to do by all these numbers of sites, almost 100 or plus, that have implemented the impact model so far?
Yeah, I think it's, I mean, for us, probably the key tool we have to have is a good registry tool. Somebody has to know, is there a person who's depressed? And if so, are they getting better? If you don't have that, you're kind of lost. So in large practices, some of the better EHR tools now have the capacity to create that kind of a registry. But it was actually remarkable how 15 years after we built the tool we used in this study, even some of the larger healthcare systems still really couldn't produce a functional registry. That is now changing. Smaller practices, it's still a challenge. And so you have to offer them a tool that's easy to use. Why would they use it? Two reasons. One of them is the kind of model I talked about requires more than one person to be able to look up very easily and very quickly about what's going on. So a web-based tool where the data sits in the cloud makes it possible for the patient to submit their own PHQ-9 or a family member. It makes it possible for their PCP to look at it if they want to. The psychiatric consultant, who might be a state away, can look at it. And the care manager who has interactions with the patients can look at it. So that kind of tool, if it really facilitates good care, a practice might be motivated to invest in it. I think the long term, where we really need to go with this is data that is the patient's and the family's data. We need to make tools that are so easy to use, or the patient and the family use it to communicate with each other and with the healthcare team. And then I think we have something really powerful.
Great. So the next question is whether there are any good examples of design thinking derived interventions in the dementia space.
Lucy?
I can think of some that relate specifically to inpatient care. And so these are interventions in which both patients and caregivers gave their input around the challenges that they were experiencing during hospitalization, in terms of putting together information from different people, in terms of knowing who they were interacting with, and then in collaboration with the clinicians, developing tools to help them kind of keep all that information together and understand what was happening. And so much of this is, you know, we think we give people information and then they have all they need. But it's really what the design thinking, I think, helps us with is to understand how people use that information, how they use the information to create meaning and to make sense. And that's what they're going to act on later.
Thank you, Lucy.
So there are a couple of questions here about tailoring interventions, such that they might be developed and tested in one setting, but disseminating them and making them work in settings that are culturally different or under-resourced, rural, where certain other kinds of community-based resources, et cetera, might not be available. You know, where do we stand with that?
Yeah, Jürgen, I think it will be really good from your experience because you've been in very limited resources environment. So it might, can you give us some insights?
About how smaller rural practices could do this?
Yeah.
Well, like I said, you have to give them a reason to do it. You have to give them an incentive. And if you say, if you have this data and it's accessible to us, we can provide you something meaningful, tangible. In our case, we have rural practices throughout our state. We have 39 counties. Only 17 have even just one psychiatrist. The rest of them will never see a psychiatrist. So if I can say to them, if you share data with us on a web-based tool like this, we'll be able to give you consultation straight into your practice. That's a very powerful motivator. So you have to have a reason for people to want to do that. It is extra work, but I think as long as something meaningful comes back, people can certainly, you know, do it.
Thank you.
And it is kind of a related question to follow up on that. You talked a lot about incentives and particularly financial incentives. Aside from financial incentives, what kind of things might work in terms of disseminating?
Let's see if, Beth, do you have any input where you're sitting on Kaiser Permanente beside $? Is there any other incentive that facilitate diffusion?
Well, I actually always start with professional satisfaction. So I think, you know, honestly, we start with physicians and other health professionals and members of the care team really want to do best by their patients. And so I think the big attraction and what we see works is when people feel that it is a tool that's effective in helping their patients. That's number one. I agree that the financial piece is helpful, but I think it starts with demonstrating that it's going to make a difference in patients' lives, because that's actually why most health professionals get out of bed every morning and, you know, go in to do a really tough job.
Thank you, Beth. I know we're out of time at 3:40, and I'll hand it back to you, David.
Thank you very much. So these were great questions. We didn't get to quite all of them, but thanks, and you can continue to submit them. We are going to break now for 10 minutes. So we will come back at 3:50 and for the last theme. Thanks, everybody. Okay. It is 3:50 and time to come back. And my job right now is to very briefly welcome everybody back and pass the baton to Vince Moore and Joanne Pike, who are going to lead the final theme discussion on research resources, methods, and data infrastructure. So Vince and Joanne.
Great, thank you, David. I'm Joanne Pike, and together with Vince Moore, we're co-chairing Theme 6, focused in on research resources, methods, and data infrastructure. This theme includes a focus on methods, data, and processes to facilitate cross-cutting, high-impact research. This includes approaches to intervention research, including pragmatic trials, and observational studies to enable monitoring of progress toward achieving research implementation milestones. Issues that will be covered today include survey infrastructure, ethical frameworks, costs, and access to data from electronic health records. Vince will be introducing our speakers. Vince?
Thank you, Joanne. It gives me great pleasure to introduce our speakers on this important topic regarding research resources, methodological advances, and data infrastructures needed to advance the care of persons living with dementia. Our first speaker is Julie Bynum, a geriatrician and health service researcher at the University of Michigan, where she specializes in using Medicare and other insurance claims data to understand the patterns of care older persons receive. She is followed by Tom Travison, who is an associate professor of biostatistics at Harvard and the director of biostatistics and data sciences at Hebrew Senior Life, a long-term care hospital affiliated with Harvard. He is followed by David Wendler, who is a senior investigator at the NIH Clinical Center in the Department of Bioethics, where he focuses on the ethics of research on people who are unable to give consent. Each speaker will have 10 minutes, and then we'll move on to the gaps and opportunities. Julie, you're up first.
Thank you very much. Good afternoon, everyone. I'm Julie Bynum. I'm professor of medicine at University of Michigan, and I'm here to talk today about how we identify people living with dementia when we're conducting population and healthcare research. Next. Next. So from my experience doing population research and healthcare research, sometimes junior faculty and other investigators will ask me, how should we, or ask for advice, how should we best identify people living with dementia for our studies? In order to help answer that question, I have to ask at least 3 more questions. The questions are, what's the purpose of your study? What are the key participant features that are important for you to make valid conclusions? And what are the trade-offs that are acceptable in order for you to meet the goals of your study? The informatics world has a term for thinking this way. They call it fitness for use, which I really like, where we're thinking about our options and data options and approach options and tailoring our decisions about what to do based on what we're trying to achieve. Next. The idea of fitness of use is so useful to me because it really hammers home the punchline that there's going to be no single best approach. If you think about our focus today, which is population and my focus, which is population and epidemiology research and healthcare setting research, even within that smaller domain of the Alzheimer's disease studies, have a wide variety of potential goals of their studies. And just to give you an example, if, for example, I was interested in doing a study of caregivers and to inform policies that might come out, I may be less concerned about what type of dementia a person has, what the etiology was. But if I was doing a epidemiology study trying to understand risk factors for, say, behavior problems, then the type, the etiology of dementia could really be very important. Next slide, please. So that brings us to the next question. What are the features of the person living with dementia that are really critically important to capture in your study? Dr. Peterson, way back in one of the earlier sessions on a different day, talked about the categories of diseases that we now use in our lexicon when we do dementia studies. And they go from studying a dementia syndrome, which is defined by cognitive and functional loss, to defining people by their specific cause of their dementia, Alzheimer's or other cause, or identifying conditions that put people at risk for developing dementia, which are people who have MCI, for example, or have a biologic phenotype that's identified through blood tests or cerebral spinal fluid to say that they might develop the dementia syndrome in the future. These are really disease constructs. And thinking about which of these disease constructs is ever more important in our field today. One, because it means a lot for our interpretation of our findings, but two, our field has become more complex and more nuanced, and it's absolutely imperative that we use the nomenclature that communicates well with our stakeholders, so they know when our studies are applying to which special population. In addition, it has important implications for our data collection. Next slide, please. If we're studying a dementia syndrome, we can identify cognitive performance and role function through surveys and possibly even through proxies in some scenarios. But if we need to know the type of disease or the severity, we likely have to do a clinical evaluation. And obviously with biologic markers, we have to collect those biologic markers. Next, please. And with those decisions, those different kinds of data, there are a lot of trade-offs. Clearly, there's obviously a diagnostic precision trade-off across these categories, depending on how much more detailed data you collect. And when you get more precision, you often get more cost. It's much more costly to collect, obviously, brain imaging than it is to do a survey. With those more intensive methods, we also have increased risk, albeit relatively low risk compared to what some of our pharmaceutical studies do. And also, very importantly, the barriers to recruitment. Some of the things that we require of people to recruit into a study, such as biologic markers, are maybe particularly difficult in some ethnic groups. Next slide, please. So when we look at the challenges for the future of our strategies for identifying people living with dementia for our epidemiologic and population studies, one of the first ones is this issue of sampling and recruiting representative populations. And it's really tied up in the cost of how we identify our population. To get a truly representative study, we need a large one. But to do that with a clinical exam or biologic markers could be very prohibitively expensive. Another major challenge for us is that with every study, you can use slightly different methods and we can, as a result, get slightly different results that may confuse our stakeholders. So harmonization of how we're doing measurement and how our studies relate to each other are very important, especially when we think about consistency over time as our diagnosis definitions have changed over time. When we want to study trends and we have long-term legacy data based on dementia syndromes, how do we use that moving forward as we collect other and more specific definitions for what it means to be a person living with dementia? And finally, as I've already mentioned, we have very limited data for the biologic measures among certain ethnic and racially underrepresented populations. So our new definitions will present challenges to even get the basic epidemiology down. I think the main point I want you to take away, though, is that we have enough nuance in our field that thinking about our disease construct and how it fits with precisely what we're trying to study is a critical step. And then the second critical step is being absolutely clear in our nomenclature and our discussion with our stakeholders about what construct we're using and how our data processes alone, aside from our theories of the disease and otherwise, but even our data processes can impact our interpretation. Next slide, please. A lot of people turn to healthcare setting data to try to address issues of cost and getting a truly representative real-world selection of people who have dementia. And we already heard reference to that in the Learning Health Systems section as well. When I say healthcare data, I mean that data that is generated in the course of delivering care. That's what reduces the costs. And the examples of that are things like billing data and electronic health record data, whether that's Medicare claims, assessment files, or the structured or the unstructured elements in a record. Next slide, please. The major challenge with this kind of data, though, is that in order to show up in that claim, you have to have a bill, you have to have this visit, you have to present for care. And while that's important for all diseases, there's some really special issues in the field of dementia. This model of how somebody comes to a diagnosis of to any kind of diagnosis from the National Academy of Medicine really helps us with that, because we know in the setting of dementia we have issues of stigma that might keep people from coming in. We also have underdiagnosis even when people do come in because of clinician skill and otherwise, and we might have people in whom the diagnosis or concerns haven't even been disclosed. Next slide, please. Many people are reaching to the electronic health record to offer opportunities to address some of those problems, because in an electronic health record, you can use some of those unstructured fields, the clinical written notes, to extract symptoms, or you can use the screening tools that are used for the annual wellness exam, for example. So that offers some real opportunities that are growing, but there's still challenges that remain. They still have to come into the clinical setting. And they also have to come into a place that has one of these electronic health records. For people living with dementia, we're often interested in home care and daycare and assisted living. And there's a major challenge of implementing these algorithms across health systems. Next slide, please. Getting beyond just identifying the yes or no, whether somebody is living with dementia, there are also special characteristics of the disease itself that are hard for us to identify currently. If you're interested in stage or severity, first, there's many ways to define that by cognitive level, function, behavioral symptoms, and those particular characteristics are difficult to pull out of existing claims data. Similarly, type of dementia is hard clinically, so you can imagine that the data that's represented in the clinical record may not be as accurate as we'd like. But for care interventions, we should be thinking really carefully about which caregiver intervention works at which stage of disease, for example, and do we have the measurement approaches to capture that fully? Next slide, please. So in summary, there's many new and exciting things going on in our field and lots of attention. People are listening to us. And so when we talk about people living with dementia, we have a real imperative to be clear and take advantage of that opportunity. But because of the nuance, we have to be especially careful about addressing the limitations of our data and the limitations of how we can interpret our findings, especially as that affects representation of the general population and how our stakeholders like policymakers and healthcare systems might use this information. Thank you.
Hi, my name is Tom Chavison. By way of introduction and disclosure on the next slide, I'm Associate Professor at Harvard Medical School. I lead the Biostatistics Group at the NIA-funded Boston Older Americans Independence Center. And like Dr. Manan, I'm a member of the Impact Collaboratory's Design and Statistics Core, which is directed by my colleague, Professor Heather Allure. Next slide, please. I'd like to first say a few words about the creature we know as an embedded pragmatic trial. I know there are many experts in this audience, and so I'll ask for your indulgence where terminology has been streamlined for clarity. Next slide, please. What I think of a so-called pragmatic clinical trial is roughly an intervention trial that seeks to preserve the characteristics of real-world care in its design and evaluation of information. An embedded trial is one in which the structure of the trial itself is contained within rather than apart from a healthcare delivery system or systems. I find it convenient to think of this as a higher level feature of pragmatism, where not only is the design of the study intentional in mimicking real-world exchanges of care and information, but also the circumstances and settings in which these events occur are as they are in real-world care, excuse me. Because of these features, these trials lack the intentional laboratory artificiality of what we might call conventional clinical trial design, what we think of in classical drug development or behavioral interventions. And therefore, these new designs are ideal for helping us quantify the practical effectiveness of an intervention, how it is likely to perform in the wild, so to speak, as opposed to the classical efficacy of interventions, which measure effects under more stringent laboratory-like control. Next slides, please. These designs have particular relevance for assessment of non-pharmacologic or systems-level interventions because of the choice to maintain pragmatism in overlapping and mutually reinforcing domains, as you see illustrated here. This feature ensures that the philosophy of design is in harmony with the principle of inclusivity in enrolling populations with diverse health profiles, excluding few individuals, looking for a diversity of settings in which the intervention can be deployed, and so on. It also focuses on clinical endpoints that are important to people living with dementia and their caregivers, which, as Dr. Lakem and others have pointed out, are best informed by interactions with the patients and stakeholders themselves. And of course, in choosing from among such endpoints, those that are tractable and likely to be widely available, which in turn depends upon deep knowledge of the kinds of resources and structural practicalities that were just discussed by Dr. Bynum. Next slide, please. So all of this sounds wonderful, but of course, there are challenges to creating and executing embedded PCTs. And as we have seen, these complexities are interwoven and inhabit all features of classical trial design, as I've tried to highlight here. Dr. Anutzer said earlier that unfortunately, the real world is complex. And that strikes me as a reasonable distillation of some of the issues that we're dealing with here. But also to revisit a comment by Dr. McGlynn and others, it's unquestionably better to consider these aspects with the greatest possible rigor, rather than treat them as mere nuisances to be avoided or ignored, so that contemporary solutions, whether technological or otherwise, can be brought to bear in the service of drawing valid research conclusions. Next slide, please. So some of these particular challenges are in the area of design, often because these trials or interventions are being applied to groups of participants at the level of a practice or a system, rather than individuals with individual randomization. So-called cluster randomization or group randomization is necessary. And also the intentional deployment of interventions in a variety of systems or settings may give rise to heterogeneity in the effectiveness of different environments. An intervention may be more effective in one place or among one population of individuals than another. Understanding that heterogeneity is an excellent and good thing, and studying it closely is a key mission of research in this area. But to do so rigorously requires more and potentially many more participants and caregivers than might be suggested in a conventional design. And so therefore, these trials suffer dramatically if the design is resource poor. Next slide. These designs may also levy specific challenges in measurement that are imposed by our desire to measure accessible participant-important outcomes. So we may be relying on routinely collected data, which has a nice feature of mimicking real-world information gathering and being tractable, in a variety of settings, but may be hamstrung by its inability to attack certain patient-important measurements. Next slide. They also, these designs also have particular challenges in terms of interpretation and analysis. And just to speak quickly about some of these, identifying mechanism of action is particularly challenging when you're working with an effectiveness design and requires closer study. And as mentioned previously, consistency across subpopulations is something that has to be studied in itself and requires much larger sample sizes or more close identification of specific issues specific to certain populations and settings. Next slide, please. These challenges, of course, present corresponding opportunities. And so I'd like to spend a couple of moments talking about those. Next slide. In the area of design, contemporary design innovations, such as the step wedge and smart designs that were mentioned earlier by Dr. Lakem, are contemporary innovations that make for specifically focused on helping us better assess effectiveness while providing greater access to potentially helpful innovations and helping us generate meaningful within-group comparisons, because each group and each individual eventually receives either a control regime or an intervention regime that helps us to address some potential challenges such as confounding by setting, as well as others. Next slide. Similarly, if we make good investment in infrastructure and be flexible in design, we can enhance the quality of measurement even under the broader umbrella and rubric of pragmatism. Establishing validity and reliability of measures obtained by administrative data and EHR and other sources, as mentioned by Dr. Bynum, also including contemporary quantitative and qualitative methodologies to make sure that our measurements are valid and explicitly applicable to persons living with dementia and their caregivers. Next slide, please. Finally, I think a focus on interdisciplinary engagement and bringing sort of all parties to the table. And most specifically, it's very reassuring to see the focus in this session and others on implementation science promote success in interpretation and measurement. Next slide, please. And finally, contemporary innovations in analysis can also ease interpretation and reproducibility of results. And it was mentioned earlier, analyses that explicitly take into account both the participant and also their caregiver as a dyad or a unit, and thinking through the effect of interventions on both members of that partnership, both in the current situation and downstream, and the interaction between those effects is now sort of a great focus of work by colleagues of mine and others, which I think will improve our perspective greatly going forward. Next slide, please. So in summary, embedded PCTs have some promise in testing novel interventions to improve the health and well-being of people living with dementia and their caregivers, but certain design features while requiring flexibility in enrollment, setting, and adherence are very helpful in this setting, also offer unique methodological and implementation challenges. Luckily, contemporary design and analysis is sort of working on some of these problems and will help us to bolster impact in the future. Thank you.
Hello? Can you guys see me?
We can see you, David.
Okay, good. So I'm Dave Wendler from the Department of Bioethics at the NIH Clinical Center, and I'm going to discuss a few of the important ethical issues that arise in doing research involving dementia. So next slide. So these are my disclosures. Just most important one is I work for the US government, but I definitely do not represent or speak for the US government. Next slide. So as widely recognized, obtaining informed consent is critical to ethical research. When we start thinking about research in the context of dementia, getting consent can raise a number of challenges. I'm going to focus on two of those primary challenges. The first one, next slide, please, is a question of whether or not and to what extent participants' decisional capacity should be assessed prior to their enrolling in a study and then occasionally while they're enrolled in that study. Next slide. So existing guidance tends to focus in this regard on individuals who are at risk for lacking decisional capacity. So a report from the US National Bioethics Advisory Commission recommended assessing people who suffer from mental disorders, for instance, that may affect their decision-making capacity. Individuals who are regarded as sufficiently at risk receive formal assessment, and others receive little, if any, assessment at all. Next slide. While this makes sense, I think it raises a number of concerns. The first one is that ethical research doesn't depend simply on having people who are capable of giving informed consent. It depends on people actually giving informed consent. The second problem is that targeting at-risk groups raises a number of practical challenges. How do you determine which people are sufficiently at risk? What do you do for people who aren't sufficiently at risk? And there's also can be worries about stigmatizing the targeted group. So I've advocated for a different approach, next slide, which is essentially assessing everybody, whether you're at risk or not. We all don't understand as much as we'd like in various cases, and therefore it's important to assess everybody's consent to make sure they're understanding and they're giving valid consent to enroll in research. In this regard, it's important to note that standardized tests, mini-mentals, MOCAs, IQ tests don't determine whether or not individuals can give informed consent for a particular study. Instead, it's important to do what's called in the field task-specific assessments. Assess whether or not an individual can give informed consent for the specific study in question. So how do you do that? Next slide, please. Typically, the determination of what's required to assess individuals' capacity should be based on the risk-benefit profile of the study. General idea is for relatively low risks and low worry studies, fairly minimal informal assessment should be sufficient. For instance, explaining the study to an individual and simply asking them whether or not they have any questions and why they want to enroll in the study. As the risk-benefit profile becomes less favorable to individuals, there should be more formal assessment conducted to ensure that they have capacity and are understanding. Next slide, please. It's important to recognize that individuals' understanding their consent can be influenced by a number of circumstances: the time of day, whether they're comfortable in the setting, whether they're paying attention, how well the information was explained to them. And that reminds us that the fact that somebody's having trouble doesn't mean that they're not able to give informed consent. Instead, we should do two things. Prospectively, we should try to maximize the chances of success, make sure we're explaining in a clear way, make sure we have a comfortable setting that's not intimidating for individuals. The second thing, there's a lot of research that shows that individuals who fail the first time, who don't understand certain critical aspects, can often pass that and understand if they're given targeted reinforcement and education. Next slide, please. So now we've done an assessment, we've determined whether or not somebody can give consent, and the next question is, who should make decisions for individuals who can't give informed consent? Next slide. So the first thing to think about is, what's the ethical concern with enrolling individuals in research who can't give informed consent? The way I think about it is what I think of as the possibility of unwanted research enrollment. So the worry is that we don't want to enroll people who can't consent in research that they themselves would have declined to enroll in if they had been able to give informed consent themselves. So what we need to know is we need to know whether individuals are willing to enroll in research if they're not able to give informed consent. So we have this relevance. What does the empirical data tell us about people's willingness in this regard? Next slide. The primary lesson is that for the most part, many individuals are willing to participate in research if they lose the ability to give consent themselves. And they're also willing to rely on a surrogate to make research, enrollment, and participation decisions for them. Not surprisingly, individuals' willingness to be in research, should they lose the ability to consent, decreases as the risk-benefit profile becomes less favorable. So for instance, as the chances for benefit go down and as the risks go up. It's also important to note that a minority, but there is a minority of individuals who prefers not to be enrolled in research if they're unable to give informed consent. Next slide. So what that suggests in terms of our question of who should give informed consent for individuals who can't make their own decisions, we need an appropriate surrogate, and the surrogate should be making decisions based on the preferences and values of the specific individual in question. So we should ask, the surrogate should ask themselves, do we have sufficient reason to believe, given the person's circumstances, what we know about them, and the nature of the trial, whether or not they themselves would enroll themselves in the trial if they were capable of making this decision. So if being in this trial is consistent with the type of person they are, with the kind of decisions they would make for themselves, it can be appropriate to enroll them. Next slide. So those are the two primary questions I want to focus on. And I want to just very briefly mention another few important questions that I think deserve further discussion and attention. Next slide, please. The first one is a movement that has started in Europe, is gaining traction, and it's sometimes referred to as supported decision-making. So basically, the idea here is that we typically, or at least standardly, dichotomize people into those who can give their own informed consent and those who can't give their own informed consent, and therefore need a surrogate, as I've discussed previously. The supported decision-making literature talks about the possibility of trying to provide the assistance that's necessary to allow all individuals, independent of their level of cognitive capacity, to make their own decisions, in this case, their own research, enrollment, and participation decisions. So this raises the question of to what extent and in what ways can we assist patients who have cognitive impairments to remain the decision makers for the research participation. Next slide, please. This is an approach that a colleague of mine recommended about 15 years ago. There's been very little discussion of this that I've been able to identify in the literature, but I think it's an interesting question, which is to what extent, if we identify someone, we do an assessment and we identify somebody that's unable to give informed consent, to what extent should that be noted? To what extent should we explain to the person they're now regarded as not able to make their own decisions? And to what extent should we then point out that a surrogate will be making decisions for them? That's often regarded as a protection, but it also raises worries about the trauma to the individual. And the question is, can we instead engage the surrogate early on and just continuously and seamlessly involve both in the decision-making process? Next slide. And finally, I focused on, as most people do, assessment of the decisional capacity of the patient. But that raises the important question about what about assessing the surrogate? If they're the ones who are making the decision, we want to make sure people understand. I think it's also critical. We have a protocol here at the NIH Clinical Center where we do assessments of the surrogates to make sure that they understand and are making decisions appropriately for decisionally incapacitated patients. Next slide, please. So in summary, answers to our questions, what should we do with assessment of decisional capacity? My view is that all research participants' decisional capacity should be assessed. Whether it's formal or more informal or more formal will depend on the nature of the study. Second, who can make decisions for individuals who've been determined to be unable to give consent? It's an appropriate surrogate using the substituted judgment standard. And as I've tried to suggest, there are a number of important questions that remain in this regard. Thank you.
Thanks so very much to Drs. Bynum, Travison, and Wendler. As with the other sessions, they'll be available for audience questions after we present the draft list of gaps and opportunities. And panelists have an opportunity to respond. So let's dive in. I'm going to take the first 5 and Vince will take the second half. Opportunity number 1, develop a public-private consortium in the form of a National Center of Excellence in Care to serve as a repository for secure data access techniques, research, and analytic models, and implementation and dissemination strategies promoting interventions that can improve the lives of persons living with dementia and their care partners. Next, undertake research to test the value of machine learning and artificial intelligence approaches designed to identify persons living with dementia and their care partners in electronic medical records and health insurance claims, and to readily measure their needs for services and outcomes of care. Number 3, conduct research on methods to engage payer and provider organizations in applied research on dementia-related care, services, and supports. Number 4, develop measures and approaches to monitor the adoption and dissemination of dementia-capable communities. Number 5 is to evaluate new and modified measures for identifying and characterizing people living with dementia who may benefit from dementia care interventions being tested in population-based and healthcare system-based studies, and for monitoring progress towards identified milestones at the national, state, and community levels. Vince?
Thank you, Joanne. Number 6 is to promote research that integrates different techniques to identify cognitive impairment, including imaging, biomarkers, cognitive testing, and functional assessment, in order to estimate the relative contribution of each approach to disease staging necessary for research. Next, please. Number 7, to develop infrastructures such as measures, surveys, reporting systems for population-based studies of persons living with dementia and care partners to monitor progress towards meeting national, state, and community milestones, including in key subpopulations of interest. Next, please. Number 8, to promote the translation of effective dementia programs and services to real-world settings by conducting innovative research using designs that increase the generalizability of research findings, including pragmatic trials, quasi-experimental designs, hybrid designs, mixed methods, rapid cycle quality improvement methods, and standardized process measurement, and consider incorporating community-based participatory research and practice-based research models to facilitate this translation. Next, number 9, to develop and test new approaches to engaging persons with cognitive impairments in research who may not have the capacity to provide consent using traditional standards. Conduct research on the use of assent and dissent with special consideration for understanding capacity, beneficence, and access to research, both for individuals with dementia and their care partners. Last one, number 10, the last one. To conduct research to guide institutional review boards and ethics committees on how to facilitate the appropriate collection of self-report data from persons living with dementia and from their caregivers. Thank you very much. So I think we're now ready to go on to our panelists. Joanne, did you want to introduce them?
I am. So our panelists today represent a broad perspective in application and use of research and data. Joe Chung joins us as a serial entrepreneur, CEO of Kinto, and as an SBIR-funded organization to build a caregiver technology platform. He will be followed by Dr. Craig Thomas, who is the director for the Center for Disease Control's Division of Population Health, a position he assumed in June 2018. Prior to this role, Dr. Thomas served as the director of the Division of Public Health Performance Improvement in CDC's Office for State, Tribal, Local, and Territorial Support. And then Dr. Maggie Miller, who is a research assistant professor in the Department of Epidemiology and Biostatistics and manages the South Carolina Alzheimer's Disease Registry, will close us out for our panelists. Joe?
Thank you so much, Joanne and Vincent. I'm Joe Chung. I should say I come from a pretty different world, I think, than the rest of you. I guess I'm a tech entrepreneur at heart, came straight out of my undergraduate and graduate work at MIT, and went off and started launching startups. So the story behind how I got to be CEO of Kinto is really a personal one, where after a couple of pretty successful ones, we took the company public. We did a bunch of that whole Silicon Valley sort of stuff. My father was diagnosed with PSP dementia, and overnight I became a caregiver. And I think, you know, the quick story behind that was as a family that had you know, really tremendous resources available to us. My father was a neurosurgeon. My brother, who was really his primary caregiver, was also a neurosurgeon. He was my father's partner. My father was also my first angel investor in my first company. And so had a kind of a big windfall of wealth later in his life. So we had plenty of resources behind taking care of my dad through the dementia caregiving process. And frankly, we did a terrible job. We made every mistake. Now that I've studied this in much more depth, I realize how badly we did it. And we started Kinto really around the idea that, you know, there's so much knowledge, there's so much experience that's happening amongst caregivers, and everyone who ends up in this position seemingly goes through it on their own for the first time. And we thought that we could really do something about driving support and coaching to that. So Kinto is a care coaching service for family caregivers with dementia. That's its mission. But as an entrepreneur and a businessman, my mission is to figure out how to turn that into a commercially viable and highly successful company that can reach real commercial scale. So I'm a huge believer in the power of entrepreneurship and the power of scalability of these startups to be able to rapidly reach millions of people and solve some real problems there. So that's really the background behind it. I think the observation from our perspective in terms of how we make this into a commercially viable venture is around utilizing and maximizing the alignment of interests behind what family caregivers are trying to achieve as in that dyad with the person with dementia, and the health system and care system that looks after that's responsible for their care and ultimately for the cost of those cares. And those are highly aligned, and something that I think hasn't been exploited enough. So that's my background on Kinto.
Craig?
Craig, are you muted or you
I
there?
am here. I am definitely here. There we go. Thank you. Good afternoon, everybody. It's a pleasure to be able to listen in and with our distinguished colleagues here. And thank you, Joanne and Vincent, for the opportunity to speak briefly on behalf of the Centers for Disease Control and Prevention. So I will definitely, because I am a public health professional, take that population-based research approach. So thank you, Dr. Bynum, for the lovely setup. It is certainly true that we focus on identifying the burden of disease for Alzheimer's and related dementia, looking closely at those risk factors, understanding where those disparities are, and then how do we translate what we know works to address some of these issues through policy and or practice. We know that, for example, that Alzheimer's has quickly become a leading cause of death and disability in the United States and likely in the world. There are approximately 6 million people living currently in the United States living with dementia, and it costs us about $270 billion annually to care for those individuals and their caregivers. Making this a little bit more complicated, typically 95% of the people with dementia often have more than one chronic condition. So this adds complexity to how we manage and treat the disease, and that we recognize and know that African Americans, Hispanics, Native Americans, Alaska Natives, and women tend to are at greater risk for developing dementia, including Alzheimer's. And then the last point I want to share is that 1 in 3 Alzheimer caregivers report that their health has become worse due to their responsibilities for caregiving. So again, making the important case for why this is a public health crisis of sorts. And we are certainly up against our issues around the pandemic, but so much of what we're talking about here in COVID-19 and the mitigation strategies that we are employing, especially around social isolation, really negatively impacting this population. And we're doing our best to help to address that issue as well. I'd like to quickly shift to my thoughts on data and infrastructure, which is obviously something that CDC is known for. We do have a number of really important data sources that I want to draw to your attention, especially as you think about designing your population-based or epidemiologic studies. The behavioral risk factor surveillance system actually measures 2 really important components for dementia. One is subjective cognitive decline, as well as we have a caregiving module. Our 2019 data are going to be released in September, so please check out that website where you can get data on all 50 states for subjective cognitive decline, and I believe it's 44 states that have reported data on caregiving. These data are essential for understanding where we should be investing our resources and time, and obviously, and Haynes is another one, the National Health and Nutrition Survey, and it's one that I think you all are familiar with, examination survey, and that's yet another really important data source. And then you should be aware that Healthy People 2020 and 2030 have very concrete objectives focusing on dementia and Alzheimer's that really do reinforce the importance of this as a public health and healthcare problem. Regarding beyond the data, I just want to highlight, you can look on our website, you'll find some data briefs as well as data for action, which really do highlight some of the statistics I just shared with you briefly. I'd like to move now to policy and practice, which is what we are about in public health. It's really important for us to translate these findings into action and have some.
Doctor, thank you so much for your thoughts. Unfortunately, we need to move on to the next presenter, but we'll look forward to your Q&A responses. Thank you.
Okay.
And Maggie?
Hello?
Go ahead, Maggie. You're on.
Okay. Hi, everybody. My name is Maggie Miller, and as mentioned, I am the South Carolina Alzheimer's Disease Registry Manager, and that is within the Arnold School of Public Health in the University of South Carolina. And I just wanted to give a little bit of my perspective working with the registry, and also just kind of discuss a little bit of the gaps and opportunities that are related to my work with the registry. So our registry captures new diagnoses of Alzheimer's disease and related dementias on a yearly basis. And we use 11 different sources of statewide health and administrative data. So basically anyone who seeks provider services within these sources and is diagnosed with dementia, they are included in the registry. We obtain our data from our partners at the South Carolina Revenue and Fiscal Affairs Office. And here statisticians create a unique identifier for each individual. And that enables researchers to link across multiple providers and service agencies. And these include Health and Human Services, Social Services, Department of Mental Health, law enforcement data, and the Department of Education, among many others. So this unique identifier allows for data linkages while also protecting the confidentiality of the individual. And in addition, all of the requests must be approved by the Data Oversight Council for the participating agencies and organizations. And I just wanted to use this as an example because it's been a very effective model funded at the state level. And if we could find opportunities to link to additional data from other states, or serve as an example for the development of similar data warehouses in other states, this would help to address the first gap in opportunity for this theme that was listed earlier. And the goal of this is to develop a national repository with both rich and secure data to help promote population level research interventions that can improve the lives of individuals with dementia and their caregivers. So thank you for your time.
Okay. Thanks very much, Joe, Maggie, and Craig. We are now going to take questions from the audience, which I think David and Jennifer have been reviewing, and which they'll be asking on behalf of the audience members who've submitted those. But we're going to start with a question, actually I've already chosen, for Dr. Bynum. Julie, this is for you. How do we establish validity and reliability of measures obtained from administrative data and electronic health records?
With a lot of work. It's very challenging. Historically, when we use administrative claims, it requires someone taking it upon themselves to do a research study, which is quite tedious, linking some sort of data set that has observed and measured cognitive status. In the case of what's commonly used at the CCW, which is the CMS resource for this, they base it on the Health and Retirement Survey, on the Adams study done back around 2000. We're actually repeating that study for more recent HRS data because, two reasons. We think that people might be labeled with dementia in different ways and may be experiencing things differently in the clinical setting. So the performance of claims may actually have changed over time because clinical practice has changed, to make the point that I made before. Electronic health records are trickier. Not many people are going to, when people talk about validation of electronic records, they're actually talking about validation of the algorithm against a billing diagnosis, not against a clinical entity. So that's one of the challenges we face right now, especially with the heterogeneity of practice and skill across different health systems, to really know that when we're doing studies across different health systems, that we're getting comparable populations.
Great. David, I'm looking to you. Or Jennifer.
You're on mute.
All right. So the next question has to do, there were a number of questions that were stimulated, I think, in part by Maggie's presentation about the dementia care registries. I'll just group them together. So should we think about a national dementia care registry? How do you generate buy-in and sustain funding for the South Carolina Dementia Registry? What is the prevalence of dementia observed in the South Carolina Registry?
Yes, hi. Well, one thing that's unique about South Carolina is that we have had our registry established by law since 1990. So we are basically by law allowed to have secondary data resources report to us when there is a dementia diagnosis. So there really isn't, you know, buy-in. It's just part of what we're provided as part of the statute. So, and I'm sorry, I missed, what was the other question?
Sure. So there were three questions. What is the prevalence of dementia in South Carolina? I guess has the registry been used to provide insight around dementia prevalence? And the other related to should we think about a national healthcare registry that Vince and Joanne, you can disseminate more broadly if that's relevant to to others to comment on.
Yes, and with our registry, we collect, you know, all diagnoses statewide, so we are able to calculate prevalence. We even look at it by county as well, and we do see variations by county in terms of prevalence. And it depends also in terms of our age groups. And we look at individuals 65 and over. I'd say the average prevalence could be around anywhere from 2.5 to maybe 3.5% in the population. Or if we look at our 85 and over population, it can be as much as 10% or more. So that's what we've seen. And right now we have data from 2016, and in South Carolina, we have over 100,000 individuals living with dementia or Alzheimer's disease. So I know we've been actually the contact for developing registries, both nationally and internationally. And there are 3 registries currently that we know of within the US. There's one in West Virginia, one in Georgia, and then we have one in South Carolina. And we are absolutely, I mean, definitely excited at the thought of having a national registry developed. We just haven't been able to standardize and get everyone on the same page in all the states involved.
So I'm going to ask Julie and then perhaps David to comment for obvious reasons.
Yeah, you know, one thing it's interesting listening to the state registry prevalence number. That's much lower than the epidemiologic studies, what we would expect. And that speaks to some of the challenge of using data sets that are based on people accessing health systems and getting labeled with the disease or not. I mean, we would expect a prevalence, you know, just higher than that, you know, 8-9% as we go in these older groups. And it's wonderful to have the registry, and it's especially useful for policy planning and services planning. It's harder for actually studying burden of disease, because I would guess that as we do a great job of advertising the services available and providing better services, more people come forward to get those services. And maybe Craig can build on the contrast between that concept and actual burden of disease at the population level.
I'm happy to jump in. Thank you. So yes, definitely. I mean, at the Centers for Disease Control, we are about a population-based survey. So the BRFSS is an example of that. And I just sent a link to Chandra so you can get many of the resources and facts that I shared today. But the challenge, of course, is in sampling. And Dr. Bynum, you already mentioned this earlier in your presentation about the importance of really, I think, thinking about what the purpose and intent of your study is, and making sure that in some way your baseline is aligned in some way to what we're reporting, at least at the national level. So that is a representative sample at the state level across all 50 states. We roll it up to provide that national estimate of 6 million currently, and that's always changing. So the 2019 data will prove even, I think, an increase as we go forward. So thank you.
So this is Vince. David, do you want to comment from sort of the ethics issue on consent as relation to the law? And what's the balance there from your perspective about individual consent and research versus a legal and public health need for a large estimate?
Well, I can't comment on the law. I don't know the law. I'm not a lawyer. From an ethics perspective, I would think, I mean, Julie was suggesting this a little bit, is that once people see the value of these efforts, they tend to be very supportive of them. So I would think in general that making these things optional, but pointing out to people the value of them would be sufficient to get people to enroll. But I don't know. I don't know if there's a history in South Carolina that led to the approach that they're taking. And if so, how, I would be curious about how it's been going and if there's been any pushback on that.
So building on this line of discussion, a question that came up is how large population-based surveys can be improved to capture severity of dementia.
So Julie, you've spent enough time with the HRS. Do you want to give that a shot? I could comment as well. Others can about the National Health and Aging Trends Study or others.
I tried to allude to that at the end of my talk because I've struggled with this myself. Different areas, the drug studies talk about severity in terms of cognitive function, but sometimes when we're in different venues, we're worried about behavioral symptoms or functional status. So exactly what we mean by severity is challenging for me. When I do things from a health policy point of view, I often use things like, are they living in a supportive housing? Are they community dwelling, assisted living, or nursing home as some way to at least get general categories. So we can do measures. I think the issue of harmonizing across various different, NHATs and HRS and the CDC measures so that we're not coming up with all separate measures of severity or staging for these population data sets would be very helpful.
Great. Another question that has come in is thoughts about evaluating the impacts of dementia-friendly communities.
So I'm not sure whom are, maybe we'll ask Tom as the methodologist and biostatistician, how did that fit sort of, in addition to the pragmatic trials? How would one evaluate sort of dementia-friendly communities as that have been emerging across the country?
I would also add, Vince, Dr. Travison, before you start, is also thinking about the implementation and the programmatic side. Yeah. I'm wondering also from Craig at the CDC, as you're funding these types of things, how are you evaluating those types of dementia-capable communities as well?
So I'm happy to go first, or if Tom, you were going to say something?
Yeah, I'll just jump in very briefly and then let you go because you probably have more specific knowledge of this. I was just going to say, Vince, and to the questioner that in a way, a lot of the pragmatic trial principles remind me a lot of classic like public health style trials, where we spent decades trying to get rid of all these extra sources of variation and differences between subpopulations and make everyone very homogeneous. So then you could test in a laboratory intervention. And now we've kind of unwinding a lot of that. And so I think that these principles that I talked about a little bit, that I'm not completely expert in, could apply for large scale comparisons of one community to the other, but we're just fraught with all of the challenges that I tried to mention. But the good news is that there are really wonderful people, much smarter people than I, working on these problems, as we speak. But Craig, why don't you go ahead?
So thank you. I would say we have some exciting news. By no means do I have a quick answer for you on that. I think it is very complex, but we are very excited. The House language currently is focused on building an age-friendly healthcare system, and that would include funding to state and local entities to support age-friendly and dementia-friendly communities. That will require, those dollars will require a strong evaluation approach. Obviously, this would be a federal effort, working very closely with our state and local partners. We also just recently released funding opportunities for BOLD, which is focusing specifically on the BOLD Act for Alzheimer's that was passed in 2018. And this is funding specifically to stand up two things. One, funding to the states, state and local health departments for building their BOLD or Alzheimer's and dementia infrastructure. And two, for developing centers of excellence. So I know that was one of the gaps or opportunity areas, focusing specifically on 3 areas: risk reduction, caregiver needs, and then early detection. So those centers of excellence are going to play a major role in thinking, advancing our work. And clearly, as this infrastructure all comes in and those resources come into play, looking for examples in other public health problems like HIV prevention, for example, where there have been decades of work done in terms of our community investments and how we can evaluate the impact and effectiveness of that. We'll be borrowing heavily from our lessons learned from other program areas to evaluate what will be coming our way. So it's exciting, but I don't have a short answer for you on the specifics around evaluation.
Jen, may I add one comment to that? One of the challenges, we talk about our national studies, and what I have found is they're wonderful national to give national weights, but they generally don't cover any specific geographic area with enough population to look at outcomes in a subgroup, whether that's a dementia group or an HIV group or whichever group you're talking about. And I think that's why people, even though I said these negative things about claims data, why people reach to that, because you have a true denominator of every geography in the United States, at least. And that gives you at least some sort of platform to understand smaller geographies, comparing progress in small areas. That really is not possible by any other mechanism, unless our digital platforms can really help us with that. So,
if I may, Julie, that's also a really important area for growth for us. We have a solid methodology for developing small area estimates using our national estimates to get at a local level, even the census tract level. Those data will be rolled out December 2019. So we're hoping that will help to address some of the issues that you're raising, but by no means is it a cure-all. It's just getting us to a more local, those estimates align very nicely with the national estimates as well and other surveys. So we're really excited about this, but by no means is the answer the silver bullet.
Great. So the last question, we're running out of time, but there were a number of questions that came in that relate to inclusion criteria. Can you comment on clinical study inclusion criteria that involve, in particular, requiring a care partner to participate, and strategies for overcoming this barrier for participations of those living with the disease who may not have or want a care partner participation? And there was another question: what if a person who with dementia does not have capacity to consent, the legally authorized representative consents, and the person with dementia says no? So two related questions around, important questions around consent.
Great, David, please. Joanne, did you want to comment at all?
No, I think Dr. Wendler's perfect. Thank you.
Maybe I'll start with, I don't know how much time we have. I'll start with the second question of what should we do when the surrogate or legally authorized representative enrolls somebody in a study and the individual themselves says no. I think the first challenge is, and this was one of the issues for further research, is trying to understand what a no means in this setting. A number of years ago, we had a woman in a longitudinal study for Alzheimer's disease who kept saying she wanted to go home, and we thought that was dissent from the research, and her husband took her home, and we found out that once she got home, she sat in her favorite chair and said she wanted to go home. And so clearly she wasn't dissenting from being in the study. She was just bothered about other things. And so the first challenge is figuring out what really constitutes dissent. And the second one then is to figure out to what extent there's problems that can be addressed. There are problems with the study, with the setting that can be alleviated that are causing distress. And then the third thing is to look at the risks and benefits of the study, particularly if it's a study that offers very little potential benefit. Then I think dissent should be considered definitive and the person should be taken out of the study. If someday we're going to have greater ethical dilemmas when we develop potential treatments for Alzheimer's disease, and then we might face the challenge of whether or not we should keep people in if taking them out denies them access to a really potentially beneficial treatment. But wow, obviously that's a long way off, but hopefully it's not that far off. And then we'll come back to that one.
If I could jump in for 30 seconds or 10 seconds on the first question. I think it's critically important that we, studies that involve care partners, that methods support those studies while at the same time not becoming so deeply entangled with it that they rely on them and just disinclude people who do not have an active care partner. So I think it's a critical thing to keep our eye on.
Thank you. So it is now time for us to turn to our closing remarks. I want to thank the terrific presentations and panelists from session 6, and welcome David Rubin back as we close out the session. Great.
Go ahead.
So this is bringing us to the close of our final virtual meeting of the National Research Summit. I want to thank the steering committee, theme leaders, the presenters, the panelists, very importantly, the NIA staff, Elena Fazio, Chandra Keller, Jessica Boaton, and Courtney Wallen, who have really made this summit so successful and stimulating. I want to also thank those of you who've joined in to the conversation today and listening and posing questions. Next slide. The presentation slides and video recording of today's meeting will be posted on the Summit website within a week or two of today. We want to make a last plug that we welcome and encourage input into the process through the request for information, which will be used as we refined our draft gaps and opportunities. And this link on the slide for the request for information will remain open and live through August 20th for your feedback and input. And I am going to, next slide, turn it over to David Rubin to have the last word.
Okay. So we're not done yet, although we're a long ways towards getting done. In the end of September, the Summit Steering Committee is going to get back together again, look at the recommendations another time, and try to finalize these with the idea that they would be going to the National Institute on Aging, and we anticipate that these will be released in early 2021 for public consumption, and then the hard work begins of taking these gaps and opportunities, translating them into milestones, translating them into research funding opportunities, and doing the research. So just to say thank you to everyone. This was not what we anticipated. We anticipated being done in the end of March, and we just want to thank everybody for hanging in there with us. I think in the end we came up with a great product, and that was largely due to the people who are on the steering committee, the speakers who are very flexible, the NIA staff, and my colleague in crime, Jennifer Wolf. So thanks everybody,